annual Patient Safety Quality Improvement Day, I want to particularly thank our presenters, our residents who have taken a leadership position and have stepped up and gotten involved in quality improvement projects. If you haven't been involved in a quality improvement project, you soon will. Graduate medical education is focusing very heavily on quality improvement and patient safety, and that's going to become a requirement for you to graduate from your program. You're going to have to be up here at one of these days presenting a project that you have been involved in. So please keep that in mind. A lot of work went into this. We could not possibly do this without the support of the Dean's office, especially Pam Scott, who put in countless hours working with presenters and getting all of the administrative requirements met. So we have to thank Pam. It's a pleasure. There she is in the back, working on lunch. It's a pleasure for me to introduce our dean. I can no longer say our new dean because he's been here a while, Dean Bruce Shack, who has some comments. Dean Shack.
Robert, thank you. And let me add my welcome to the group and also my congratulations to all the presenters. I mean, it's hard work putting these programs together, and you are to be congratulated whether you win the award or not. You are to be congratulated on being one of the chosen ones to be on the podium at this meeting this morning. It is important. Quality improvement is not just a term that we use. It's actually a goal that we have to try to really improve not just the patient experience at our campus, but also the physician experience. Both of those work together to improve outcomes. And so this morning we're going to hear a lot of ideas about how we can do that. And I want to thank everybody who's here, the attendees, the presenters, and our judges especially. And again, my thanks to Pam for all the work she's done to get this put together. So let's get going, guys. Congratulations.
Thank you, Dean. We also have to thank our volunteer judges who have made this possible for us this morning. They include Pamela Gordon, Erlanger Vice President for Patient Safety and Quality, Sonia Reed, Erlanger Process Improvement Director, Mr. Mike Bettinger, Erlanger Senior Director for Quality Analytics, and Dr. Jan Keys, Erlanger Senior VP and Chief Nursing Executive. So with that, we're ready to go with our first presentation from Pediatrics. Dr. Ryan Dias will be talking about diabetes distress screening.
Good morning, everyone. Hopefully I'm not too loud here. Thank the guy in the back for that. Like you said, I'm Ryan Dice. I'm one of the second-year pediatric residents, and I have a special interest in diabetes. Promise, if I am slurring my words up here, it is not because my diabetes is not in control or I'm up or down. It's that I'm coming off of a 24-hour call and I'm a little sleepy at this point. So bear with me. I wanted to introduce diabetes distress screening to our pediatric endocrinology office with the help of our head of pediatric endocrinology, Dr. Pamela Clark. So she was my mentor and advisor for this project. So kind of definition of what our problem is here. And chronic medical conditions suffer from increased incidence of distress leading to clinically significant depression and he's telling me to use the microphone. Depression and other adverse outcomes. One of these is certainly type 1 diabetes mellitus, particularly in the pediatric endocrinology clinic. It's by far the most common diagnosis that they see down there. And it is certainly a chronic medical condition that we need to be aware of. However, this can be said across many different disciplines with any chronic medical condition. in the pediatric endocrinology office, there was no tool to assess distress or depression in the type 1 population. So my aim was to try and get 70% of our type 1 diabetics who were 12 years and older, who were seen at the pediatric endocrinology office during the time period of May 1st to July 1st to be screened for distress using a diabetes distress screening scale, which is a little bit different from necessarily depression screening, because you may not truly be depressed, you just may have some distress with, say, your diabetes regimen, or the amount of time and education that your provider is giving to you, but not true outright depression. So some of my measures, my outcome was the number identified of having clinically significant distress or depression. My process measures were percentage of patients 12 and older who had type 1 diabetes who underwent screening at their last visit at the endocrinology office. And some of my balance measures was I really didn't want to increase patient wait times. They wait long enough in our offices for one reason or another. Having them fill out a screening tool and increasing their wait time further is not something I wanted. I also wanted to make sure that I wasn't overburdening anybody in our offices with having to pass out this tool or having to grade this tool. So I wanted to make sure that the office staff and the providers didn't have an increased burden. So in the first cycle of my PDSA cycles, I just needed to find an actual tool. So my plan was to implement or create an appropriate screening tool for diabetes distress. Do was identify existing tools to see if I could use any of those. Study, let's research those tools and possibly implement and modify them if needed to meet my goals. And our act was choose the appropriate tool. Pretty straightforward. And hey, our friends in family medicine and the annals of family medicine had something that was already created. It had both an English version as well as a Spanish version that was able to be fit onto one page. So you could just fit it on one page. One side was Spanish, one side was English, and had 17 screening items that had 4 areas of emphasis, including emotional burden, physician distress, so are we doing something that is making their lives more difficult and stressful? Regiment distress, are we creating something that they just can't do at home? Is this too much for them? Or interpersonal distress, do they feel like their family cannot help them or their friends aren't supportive of them? So after identifying this tool, we needed to actually put it into practice. So we needed to implement the screening tool into the office and screen all of the type 1 diabetics who are 12 and older for distress. And I chose 12 or older just because I wanted to make sure they could understand the questions that were on that and answer it themselves instead of having mom or dad try and fill that out. Additionally, you see increased distress in our teenage population and increase admissions to our ICU units for diabetic ketoacidosis at about that time. And hopefully a secondary goal was to hopefully lower some of those admission rates if we can intervene. So we needed to introduce this paper screening tool into the daily workflow via the nurses when rooming. Implement this flow when they're just rooming the patients, that's all. And then we needed to identify any barriers for screening. Unfortunately, my results didn't exactly come up where I had hoped. There's a few things that I think may have contributed to that. I only had 24% of the eligible patients screened. But if anybody else remembers something else that happened at the beginning of May last year, about a year ago, I think we were all swimming in the deep end very quickly with the implementation of EPIC. It went fairly smoothly, but I think we all had to really tread upstream to try and make sure that we understood it. And I think that implementing a distress screening tool on top of trying to learn EPIC may have been the wrong time to do that. No worries. Give me a chance to dance. So not all the staff were trained at the same time. Some were just as needed nurses. So I wasn't able to discuss implementing this tool at the same time with all of them. And therefore, sometimes this was forgetting to be distributed within the clinic. Additionally, whenever I was not in clinic, it just kind of stopped happening, which after some discussion is somewhat of a convenient sampling. So whenever the guy's there, go ahead and distribute this. But if he's not there, that's okay. It's not at the top of our list of items to take care of. So unfortunately, only 24% were screened. However, some future plans. I think that re-implementing this tool at this point may go a little bit better just based on timing. Additionally, having the tool being distributed by the patient service representatives at the front desk, when they exchange their blood glucose meter, they receive a diabetes distress screen in return. It's kind of a trade-off. You give me a nice, really expensive device, and I'll give you a sheet of paper with 17 questions on it. Additionally, future plans would include a standard protocol for trying to intervene. What happens when we have someone who has distress on this screen? There's nothing in place for that yet. Do they get referred to child psychology, child psychiatry? Is it something that you can address in the office? Additionally, when do we need to rescreen people that either screen negative or positive? We also need to examine coexisting factors that may be unique to diabetes mellitus that may contribute to distress and depression. And then investigate any need or availability of teen support groups that may allow peers to talk with each other and help each other out in that manner. I think I see a big old sign that says my time's up, which is good because I'm at my references slide and I'm available for any questions that you may all have.
If you were to identify now the first next step, you mentioned several, what would you pursue as your additional research?
So first off, we need to get much better results. I need to increase the number of screens actually being filled out. Once we actually have that in place, I think the next most important piece would be to identify what do we do with this screen. It's just a sheet of paper now that's being filled out, but what do we do when we identify that this is physician distress? I would hope that if we identified physician distress, it would be something that the provider at that visit and future visits can continue to work with the patient and build up a good relationship with them. If it's interpersonal distress, maybe they need to be referred out to psychiatry, psychology, someone to work within the family so there's a better trusting relationship within the family. Absolutely. Thank you, everyone.
Our family medicine program has several projects. Next, from Dr. Megan Brown as presenter, improving documentation of cancer screening exams. Dr. Brown.
So I'm Megan Brown. I'm a third-year family medicine resident, and our project was improving documentation of cancer screening exams. So our aim statement was to increase to 80% the percentage of patients aged 65 to 70 who have a documented, up-to-date colonoscopy and mammogram in the EMR. This is our team. So Dr. Garrett, Dr. Sherwood, Dr. Dasso, and myself. We started on September 1st and officially ended our project on March 31st. So the current problem is with changing EMRs, we often can have inaccurate documentation of patients' medical history, tests that have been done, and this inaccurate information or incomplete documentation can lead to missed opportunities for care or incorrect tests being ordered. As family physicians and as primary care physicians, we're at the front lines of prevention, so this is really important information for us to have in the charts. These screening exams not only impact patient care and health, but they also are starting to really impact physician reimbursement, so it's important for everyone. And as was mentioned earlier in our recent switch to Epic, we found this inaccurate documentation to be a widespread problem, and so decided to try and fix it. So our desired condition was to improve the documentation of screening exams, and specifically we wanted to focus on a small population that would be able to really make a difference instead of trying to focus on our entire patient population. So we focused on those who are at the prime age to benefit from these exams. And as an aside, we wanted and hoped to bring awareness to the need for physicians to be ordering these tests, and also to provoke discussion with our patients about why they need these tests and why they're important. So these were our PDSA cycles. Cycle 1 included identifying those patients 65 to 70 with or without a colonoscopy and a mammogram documented in Epic. We then used Epic to query those tests and make lists of exactly what patients had them and what patients did not. We found in our study portion that 44% of women were found to have a documented mammogram, and 22% of men and women were found to have a documented colonoscopy in the chart. We then met with our group to brainstorm the best way to increase documentation and plan a specific intervention. We decided that a physician-led intervention would be the most time and cost-effective and would place the least amount of burden on our office staff. And so we created physician lists containing patients. So each physician had a list of their patients who were lacking documentation. We passed those lists out to the physicians, and we suggested that they try to complete at least 5 of the patients on their lists. Some physicians had less than 5 patients on their list. Some had a lot more. But we suggested they do at least 5, and if they wanted to do more, then great. They were given 1 month to address this, and a reminder email was sent at 2 weeks. We sent instructions via email on exactly how to address these lists, and basically what the physicians did was looked in the chart to see if they had a test documented. If they didn't, then we suggested they call the patient to find out if they'd actually had the test, and if they hadn't, then hopefully to provoke some discussion about ordering it and getting it done. As of March 31st, the women had increased documentation rate of mammograms to 54%, and the colonoscopy rate almost doubled to 42%. Obviously, that didn't meet our goal of 80%, but it was a pretty significant increase. And then we discussed barriers to obtaining this documentation. Some of the things we ran into were this patient doesn't even come to our clinic anymore, but I'm still listed as their primary care physician. Or the patient refused to have a colonoscopy. They might be open to other testing, but they're just not going to do it. And then that's where our project officially ended, but there is a 3rd cycle, which is still in progress. And we have been discussing with our CPC Plus personnel the feasibility of obtaining this documentation prior to wellness visits. So they'll actually call the patients prior to their visit and find out whether they've had these tests done so that we can know that information already and take the time to discuss it with them at their wellness visit. This started on April 18th, and it's promising so far. So in summary, our colonoscopy and mammogram documentation rates increased, not to our goal, but there was a significant increase. We did find that achieving a high rate, such as 80%, would likely require multiple sources. So we're not going to be able to do it on our own. We're going to need nurses, front office staff, and really patients participating as well. We found that EMRs can be a really helpful tool, especially high-tech EMRs like Epic, but they're only helpful if they have the correct information in them, and sometimes switching to a new one can cause some delays in that. I think more education for physicians and scribes when they have them about how exactly to document these tests and how to document alternatives. So if a patient doesn't want to have a colonoscopy, but they have a FIT test or a Cologuard, how do we document that to show that a screening test has been done? And then lastly, of course, patient education is always a big one, telling patients why these tests are important and getting them to have them done. And that is all. Any questions?
Okay, next from family medicine, Dr. Yuri Sawa. 9 is not benign, improving A1C in very poorly controlled diabetic patients.
Hi, I'm Yuri Sawa. I'm a third-year family medicine resident, and our QI project was called 9 is not benign, improving A1C in very poorly controlled diabetics. So our aim statement was to decrease hemoglobin A1C in type 2 diabetics with A1Cs greater than or equal to 9% seen in our clinic to an A1C of greater than or equal to 8% in at least half of these patients that were identified by March 1st. So our goal was to attain better glucose control in these high-risk type 2 diabetics. We hope to achieve at least a 1% improvement in A1C in at least half of these patients. And ultimately, the patients were the people who would be affected most, as they are the ones who face the morbidity and mortality that comes with having type 2 diabetes, but also with the healthcare system cost and utilization, since diabetes is a major cause of several complications, acute on chronic disease, renal failure, infections, and so on. So our project was from October 1st until March 1st of this year. Other residents included Drs. Ager and Drs. Keys, and Dr. Elizabeth Close was our attending physician, and Marquisa Winters was also a key participant. She is our chronic care manager who helped with PCMH and assisted in getting information to some of our patients. So why do we care? Diabetes is the 7th leading cause of death in the U.S., and in 2017, it cost over $327 billion. Diabetes-related complications include heart disease, stroke, kidney failure, limb amputation, infections, and much more. And currently, there's no standardized program at our practice to systematically target and guide therapy in poorly controlled diabetics with an A1C of greater than or equal to 9. So our desired condition, why do we care? Well, we know that reducing A1C by 1% can reduce the risk of microvascular complications, including eye, kidney, and nerve disease, by up to 40%. So diabetic neuropathy, retinopathy, just the chronic kidney disease that we see a lot caused by diabetes, all of that can be our microvascular complications of diabetes, and we can reduce that by every improvement in A1C that we can achieve. So how do we do this? Education and counseling is obviously the very key factor. Patients sometimes don't truly understand the extent of diabetes, what it is. They can't necessarily feel the effects of this disease on their health. But something that as physicians we have a lot of control over is optimizing medical therapy. And so with all of these together, we can improve their uncontrolled sugars. So our vision was to implement a systematic treatment plan to decrease the A1C from greater than or equal to 9 to less than or equal to 8%. So we chose our target group as just type 2 diabetics, so this did not include type 1 diabetics, seen within the past 3 years at our clinic with a last recorded A1C of greater than or equal to 9%, and also those that were not managed by endocrinology or another outside clinic. Our metric was either point-of-care A1Cs or serum-drawn A1Cs. So these are our PDSA cycles. So the first cycle included identifying these patients and using Epic EMR to help us identify this target population. Again, we were about 3-4 months into this new EMR, so we did have to manually search through this population. There were lots of errors, A1Cs, diabetes, patients who did not actually have diabetes, or combing through those that were seen by endocrinology. So in the end, we identified 86 patients, and then we got this list and provided it to our schedulers who were to arrange office appointments specifically to address diabetes only. So then we also designed the specific treatment plan to actually guide the physician providers during the office visit. The thing that we focused on with these treatment plan forms were that they were just easy to read, very concise, kind of step by step, so that it was efficient and simple for the physicians who have a busy clinic with lots of patients during their day, so that it was a lot more easier to use for them. So the patients were then seen, and these treatment plan forms were filled out, and then we collected and reviewed all of our results, and then also made sure that they still met our inclusion criteria. Some were actually, in fact, managed by endocrinology, which we were not able to find in the EMR, and so on. So we were not able to achieve our goal of less than or equal to 8% in half of our patients. However, we were able to achieve a decrease in A1C by an average of 1.8% in those that had completed treatment plan forms. So then we identified the barriers in completing these forms, and right now we're more in the cycle 3, where we have disseminated these findings to our providers, letting them know that with these treatment plan forms we were able to successfully lower these A1Cs. And again, we'll have to use Epic to re-identify more patients, as this patient population is a dynamic population, since A1Cs can obviously change. And then also to attempt to recontact the patient, and also to re-educate our providers and nursing staff to make sure these treatment plans get completed. So this is just a picture of what our treatment plan forms looked like. So you can see just from the top, it basically goes step by step, first line treatment, and at one glance you can see how it's dosed weekly, daily. If patients are very against subcutaneous administrations, you can go down to the by-mouth administration and contraindications that are just very easy and user-friendly. So in summary, we found that using a guided treatment plan for poorly controlled diabetics can successfully decrease A1C with the combined efforts of the staff physicians and patients. Unfortunately, only 8 patients had completed treatment plan forms as compared to 53 who were seen for diabetes but did not have the forms completed. However, 8 of these patients that had documented A1Cs of greater than or equal to 9% did not achieve our goal of less than 8%, but they all had A1Cs greater than or equal to 10%, and some even up to 14%. So even the 1.8% decrease was pretty significant because their A1Cs were just so high. And those who did not have treatment plan forms completed only had a 0.9% reduction And out of the 8 that had the forms completed, only 1 had an increase, and that increase was by 0.7%, as compared to 1/3 of those that did not have forms filled had an average increase of 1.4%. So we did have several barriers, the biggest being scheduling the actual appointments and making sure they had follow-up. Only less than 2/3 of the patients who we identified and called actually showed up to the appointments. And some of them had not been seen for several months or years, and as a primary care facility, they want all these other issues addressed. And addressing such poorly controlled diabetes is very important, and it would be very difficult to address 3 other issues at the same time. So we really had to prioritize and make sure essentially what the patient was there for. The other big barrier was obviously actually completing these forms. This was a resident clinic. It's very hard to have all the providers in one place at once to kind of inform them exactly what we're doing and exactly how we would like for the things to be completed, and also making sure they know where these forms are and locating other tools and resources like our PCMH providers. And then also that we're seeing other patients, so sometimes we're not familiar with other people's patients. So in the future, we hope to focus on greater efforts to implement and actually complete these treatment plan forms and have scheduled follow-up every month with these patients, and also to try to check the A1Cs monthly, which isn't usually paid by insurance, but to be able to take care of that so that we can have more data points. And my time is up. Yes, sir.
One of the slides was a little fuzzy. Was the age under 65?
Yes, so initially we had targeted under 65 just because if we try to be careful with tightly controlling the elderly population, but in the end we actually decided that this would cover all populations with an A1C of greater than 1% or 9%. Other questions?
One more question.
Mm-hmm.
I was wondering, for the patients that were below 65 and you wanted to monitor the A1C monthly, if their insurance didn't cover it, how were you planning that?
So just we have our point of care machine in our clinic, and we were just going to check it without charging. That was what we had talked about, and we didn't actually implement during this round, but that's kind of in the future, hoping that if our clinic is just able to check without actually submitting the charge. But that would have to require the providers to make sure they don't order it through the Epic system and just make sure that it's just a nursing check so they wouldn't get charged. Mm-hmm.
Continuing from family medicine, Dr. Newcomer is going to speak on improving hypertension monitoring with proper measurement technique at the UT Family Medicine Center.
So I'm Psqi Newcomer. I'm a third-year family medicine resident. This is my QI project, like Dr. Forrest said, improving hypertension monitoring with proper measurement techniques at the Family Medicine Center. Our aim statement was to improve the percentage of hypertensive patients between the age of 18 to 65 with a last recorded blood pressure of greater than or equal to 140 systolic or 90 diastolic by 30% by April 1st, 2018. My team was Dr. Stephen Fox was our faculty. I was the lead, and the key participants were Dr. Stephen Kinzer and Dr. Sarah Conway. Our start date was September 1st, and this went through March 31st, 2018. So what's the current problem? Why do we decide to do this? Hypertension has many risk factors, as many of you guys know. The most likely problem of elevated blood pressure is usually poor lifestyle choice, and this includes poor exercise and poor diet. But one factor that is often overlooked in hypertension is how we measure the patient's blood pressure. A lot of time it's the nurses bring them back, they check the blood pressure and just keep moving, and that's all about the flow. So we're not checking it appropriately. So that was what we decided we could try to address on our end. So the desired condition, hypertension, leads to a variety of health issues, and if it goes unrecognized, it can lead to a lot larger health issues. So our goal was to accurately diagnose and treat patients for a long-term health benefit. Our target population, patients at UT Family Medicine that have been there for the past 2 years, with the diagnosis of systolic blood pressure greater than 140 or diastolic greater than 90 in the age range of 18 to 65. So our PDSA cycle, the first part of our plan was to identify those patients that had been seen in our clinic in the past 5 months with a diagnosis of hypertension and a blood pressure greater than 140 systolic or 90 diastolic. How do we do this? We used Epic, and then we found 1,020 patients in our clinic that had uncontrolled hypertension between the data of April 1st to August 31st. So our first action was to arrange a time to meet with our nursing staff, have it in service, and discuss the proper techniques and timing of blood pressure checks. We also got the nurses all their own individual blood pressure cuffs. So during this time, we did random spot checks to see if the nursing staff were using these blood pressure cuffs appropriately, if they were checking with the patient having a back support, feet flat on the ground. They weren't testing or checking their blood pressure on the bed, that they were raising their arm to the appropriate level. We noted that during this, these procedures were being done irregularly. So we had a discussion. I had a discussion with our head nurse and tried having another talk with our nursing staff to see if we can rectify this and get it changed. So the next part of our PDS cycle was after the 5 months were over, we did another query in Epic to see how many patients were still uncontrolled with the change in our procedure. We found 1,018 had uncontrolled hypertension on their last visit during this time. So not a big change. We went from 1,020 to 1,018. So where we went from there was kind of assessing why we got these numbers, and some of the thoughts that we had were really this intervention had no effect at all because it doesn't help. Maybe the protocol is wrong. Other possibilities were we were searching in Epic erroneously. There were a couple of us that looked and we would get different numbers when we would look. And then also we got accurate data, but there was no change due to either the provider behavior or the nursing staff behavior. So our follow-up, changing the technique really didn't decrease our number of uncontrolled hypertensive patients during our QI period. Again, it's unclear why. We did have issues with the EMR, which I just talked about, people getting different numbers. And then another issue we had with our nurses would put in a set of vitals, and then when they'd recheck, they'd put in another set of vitals. So are we getting 2 sets of vitals on the same patient? That was something that we are unsure if that's how it is. And then when I talked to the nursing staff, asked if they had been doing the blood pressure checks as we had discussed, I got a variety of answers from no, I forgot, to oh yeah, sometimes, which probably was the no, I forgot as well. And then one nurse was like, yes, every time. So what's next? Next step in assuring accurate blood pressure monitoring. So continue the protocol that we've set in place, continue monitoring and reassessing with the nursing and also with the physicians to make sure we're getting good information put into Epic, and then also making sure that we are getting the appropriate information out of Epic. In the big picture, I don't know if the monitoring is going to be what really changes patients' blood pressure. I think it's going to be more continued education on diet, lifestyle modification, and medication compliance. That's all I have. Any questions? Yes, sir.
You know, sometimes you'll see an improvement, but that's still not as far from optimal. So do you consider any improvement a control?
No, not. If their systolic was still greater than 140 or their diastolic was greater than 90, they'd still be in the uncontrolled category, and that's where we, lumped them in. And that's also kind of our query under not fully knowing how to, if the nurses are putting it in at two places, is that person getting counted, with a bad blood pressure twice, or is it just once, even though the recheck was good? That was kind of a struggle that we had issues with.
I was thinking that, just checking the blood pressure a couple of times while the patient's there, that would be how you could tell whether it was being done right or not in the beginning. But just checking with people's blood pressure, making sure that, you have the right thing down in the record would not change patients' behavior at all. So,
absolutely.
I think you might be, the design of it needs to be changed a little bit so that, your outcome is going to be something that has to do with what the nurses are doing instead of something that applies to the patient.
Right, and that is something we had discussed after all the results are, if our goal is to decrease the hypertensive patients in our clinic by 30%, but we got to make sure we're doing stuff correctly on our end, and that's why we set up this protocol to make sure we're getting accurate blood pressure results. So then when we move on with this, we can start addressing the diet, lifestyle, and compliance. And that's, at the end, that's why I was saying I don't think that this is really going to change anything. It's going to be, us educating our patients.
Another observation, I'm not sure if people's blood pressure might change in an hour or so, when they're in the clinic.
Well, so our thought behind that is the way it was working is our patients would get called back by the nurses. They'd go right to the triage room. From the triage room, they'd have their blood pressure, temperature, weight, and all that checked, and then they'd get moved. And that's inappropriate. So the recommendation is 5 to 10 minutes in a cool, dark environment. And so that's what our plan was, having their feet planted on the ground with a good back support. And even doing that, there are, I'd say at least half my patients had pressures that dropped. Doesn't mean that they always came down to a controlled range, but they did come down. I don't know if that answers the question.
I was just, if you're going to use those couple of measurements to see if your work is being effective, if it's going to change anyway, that might need to have some control in there somehow.
We are right on time, right to the minute, and I want to thank our presenters. They're well prepared. Next, from Family Medicine, Dr. Ashley Salvaggio, reduction of select high-risk medications in Medicare patients at the Family Medicine Clinic.
All right, so as he said, I'm Ashley Salvaggio. I'm a third-year family medicine resident, and our project was reduction of select high-risk medications in Medicare patients at UTFP. So our aim statement was that an intervention with a specific office visit devoted to the high-risk medication and pharmacist recommendation would result in a 25% reduction in dosage of targeted medications versus the control group over a 4-month period. So this was our team. So residents involved were myself, Dr. Bodie, Dr. Fedusenko. Our faculty advisors were Dr. Haynes and Dr. Talbert. And then we collaborated with the clinical pharmacy department, who really helped us out a whole lot with this project. So I want to recognize them. I think we have one, Dr. Turner back there, who's here. So current problem, or the reason we did this study. So I'm sure a lot of you are probably familiar with the Beers list. So it's a list of medications that are known to produce adverse events in the elderly. So including falls, delirium, just a lot of problems in the elderly population. So, we wanted to see what we could do to help get elderly patients off of these medications. And so we wanted to address challenges in deprescribing. So deprescribing, what we mean by that is either complete cessation of a medication or dose reduction as well. We wanted to measure that too, as well as frequency reduction. And so this impacts patients, but it also impacts us because there is a monetary incentive from Medicare through CPC Plus. So what CPC Plus stands for is comprehensive primary care, and it's an alternative payment model that includes performance-based repayment. So I don't know all the ins and outs of it, but it's just a new payment model. So our population was UTFP patients 65 or older who were on the Medicare CPC Plus attribution lists that are also prescribed one of these select high-risk medications. And so our intervention was to first send the patients a letter just notifying them that you are on one of these high-risk medications, and we would like to meet with you to discuss that in further detail. And they were also given some information about why it might be beneficial for them to come off of one of these medications. The intervention also included a phone call from one of our office staff inviting them to schedule an appointment with their PCP to discuss it. And then in addition to that, whoever patients were in the intervention group, the pharmacist would send the PCP a letter, like through Epic, with just general suggestions on better or alternative medications, or maybe a dose reduction idea, just to help out the PCP, to take the burden off of them. So this is just a copy of the letter that was sent to the patients. Probably too small to read, so I'll just go quickly. And then this was some of the information that was also sent to the patients. And so this is a list of we chose these 5 classes of high-risk medications. So benzodiazepines, TCAs, muscle relaxers, antiemetics, and first-generation antihistamines. So all of them pretty commonly used medications, and all of them not ideal in our elderly patients. So our desired condition was to decrease adverse events in the elderly by deprescribing these high-risk medications, again, either by cessation of the medication or dose reduction. And so we basically measured the baseline of drugs that the patients were on at time point 1, and then at the end of our study, we again took the same measurements. And so this is an example of several of the quality metrics that Medicare uses for this CPC Plus repayment model. So I highlighted in blue why ours is important. So this is one of the quality metrics that they use for their incentive-based repayment, use of high-risk medications in the elderly. And so they basically will repay you based on where you are in the percentiles compared to your peers. And so this is actually data from UTFP, so we definitely have work to do in this particular area. So these are our PDSA cycles. So like I said, the first cycle involved just identifying these patients 65 and older on these high-risk meds. And then we collected the data of what medications were they taking, what dose, what frequency. And then we identified 74 patients that fit these criteria. And so they were randomized either to the control group or the intervention group. So we had 39 patients in the control group, 36 in the intervention group. And then the letter was sent to them as I described it, and they were called by someone on our staff inviting them to schedule an appointment to discuss reducing these medications. And then we did, a similar data collection at the end of the period. So in March, we again looked at the same patients and looked at their medication list, who was on which meds and what dosages. So this is a little bit of our data. So in the intervention group, so the people who got the phone call and the letter, 4 out of 36 actually had a documented, dedicated office visit. So that's not very promising, only 4 out of 36, but that's better than none in the control group. However, it unfortunately didn't look like the intervention was very effective because the high-risk meds percentage reduced was higher in the control group. So we had a 25% reduction in the control group versus 15% in the intervention. And then meds discontinued was 21% in the control group versus 15% in the intervention group. We also looked at new medications added or increased, and we had just a 2% increase in the control group. So there were a good amount of limitations. I think some of the biggest ones would be that patients, it's a resident clinic, so you're not always going to see your primary care doctor. You're going to see different residents who might not have got that letter from the pharmacist that made it a little bit easier to get patients off of these medications. The patient has to be motivated to come in for a separate appointment, which is, it's hard enough to get them in here for things that they really need. And so they have to desire to come in for an appointment to get off a medication that they probably enjoy taking. So they're not going to have a whole lot of motivation to do that. And then it also takes time and resources from our office staff, the doctor, the office staff that's making these phone calls, the pharmacy staff who is not only looking through the patient's chart, but also discussing with the physicians dose reduction plans and alternative agents to use. And then also a limitation would be, since we switched medical record systems, a lot of patients' medication lists were incorrect. So it might have shown, some old Xanax that they haven't taken in 5 years, but it showed up on their medication list in Epic. So potential improvements were to, obviously we want a complete medication history at every appointment. That's always our goal, but it's challenging to do because we're limited by time, especially in primary care. Things to make it easier would be the ability to create a flag or an alert in EMR, kind of like you can do those little sticky notes to yourself, but not everybody can see those, whereas back when we had Centricity, you could make a flag to where everyone would see that and know right away this patient is on this medication, it's high risk. So an idea that Dr. Bradford, one of our pharmacists, had mentioned was an icon in Epic, on the medication list, just alerting you when you see a list of their medications that this is a high-risk medication. I thought that was a really good idea because it's simple, and I think that could easily be implemented in Epic. And then continued attempts to contact patients to schedule a visit. So not just the one phone call and leave a voicemail, but keep trying until they either decline the visit or schedule a visit. And I think my time is up, so I will stop there. Mm-hmm. Yeah, there were 39, I believe. I'm sorry, I didn't put it on that slide, but there were 39 in the control group. Mm-hmm.
In your study, did you ask the patient if they take something else besides prescribed medication? And I mean the vitamins, the antioxidants, other natural products, or over-the-counter medication like anti-ulcer, the first one that comes to mind, there are identity of cymetidine that we know that interfere with the CYTs and therefore affecting the kinetics of some of the drugs.
I'm not entirely sure what conversations were had during those office visits because I personally wasn't one of the PCPs that completed that office visit. But I don't know that it went into that much detail. I think it was more focused on reducing the questionable medication or trying to transition them to a preferred agent.
Because unfortunately, some of the side effects are not just due to the medication,
Mm-hmm.
but to the alteration of the kinetics.
Mm-hmm.
So it looks like this started out as a kind of a quality project, and you decided to embed a study, which is ambitious. Since the de-escalation of meds is so hard in the elderly, your intervention with the PCPs ended up being a male contact. Was there any other intervention with the PCPs in helping them figure out how to de-escalate meds in these patients who usually want to keep taking them?
Well, the pharmacy residents gave a lecture as well to, at least to our residents. But the main intervention with the PCPs was a letter in Epic from a pharmacist explaining, possible choices of how to get this patient off of the select medication.
One other comment that for the leaders in the room, that having a vetted pharmacist out there in real time, be able to say, hey, you're on some high-risk medications, why don't you go talk to our pharmacist, will probably go a long way to reducing risk for our elderly population.
All right, thank you.
And now turning to internal medicine, Dr. Stephen Psqi, reducing door to doctor time.
Good morning, I'm Steve Psqi. I'm one of the third-year internal medicine residents. So our study was entitled Reducing Door to Doctor Time. Basically, we were trying to cut down the amount of time that it takes when a patient walks into our clinic at UMA until they're actually seen by the physician. Here's our aim statement. So to decrease patient wait times from a baseline of approximately 60 minutes to 30 minutes in the UMA clinic during the time period from December of 2017 to February of 2018. Impacted stakeholders are the Dodson UMA Clinic, our residents, support staff, and of course the patients. Here's our team, our leader, Sana, back there. Jennifer Samuel, myself, and Richard Tang all worked on this project together. Our mentors were Dr. Wooten, Dr. Malakoff, Dr. Carey, and Dr. Thomas. And then Cass Jackson was our senior process improvement consultant who helped us out with this, and we really appreciate everyone's involvement. So the dilemma that we faced, the average patient volume for a second and third year resident is about 6 patients per half day on average. The average wait time from when a patient walks into our clinic until they're actually seen by one of us range from about 45 to 60 minutes. And this has a direct impact on the patient satisfaction, on their compliance, on their return rates, and on their overall attitude towards us, towards the clinic, towards the staff. So we wanted to try and fix this. The goal was to evaluate the patient flow process and try to reduce the time taken until they saw the physician to about 20 to 30 minutes. And we actually sent Richard into the waiting area kind of incognito with like a hoodie and some sunglasses on to try and watch this. And he actually was able to observe it. He didn't, unfortunately, make it all the way to the process of getting roomed himself. The nurses caught on, but we were able to get some valuable information from him. So running through our PDSA cycles, so with the plan, the baseline data for patient wait times would be collected for 1 clinic cycle in the month of December. We would then apply the intervention in the subsequent clinic cycle and obtain data during that one, and then compare the post-intervention with our baseline data to see what the improvement could be. All data is recorded in Epic, and this is represented by a red dot when they're first registered to a green dot, meaning they're ready to be seen by the physician. And we can log all of that information just in our normal Epic system. Each resident, what we decided to do was each resident would be assigned specific rooms that they could only see patients in, and there would be 2 nursing staff members assigned to the resident team specifically. We felt that this was our lowest cost option that could have potentially the highest impact on patient satisfaction, on efficiency of the clinic. Before we did this, we met with the staff members, the nursing team, and tried to discuss any issues that they may have with this, any concerns they would have before we implemented the plan. This is the process flow map, and this is what Cass worked on us with. I don't have time to go into all these, and I don't expect people to be able to read the actual sticky notes, but I just wanted to make a point that each one of these sticky notes represents a stop point from when a patient walks into our clinic on the far left until the far right when they're actually ready to be seen by one of us. So there were a lot of areas that we could work on, and that's just kind of how we went about choosing our specific intervention. So what we did was assign 2 specific exam rooms per resident. You could only see patients in these 2 rooms. The patient had to be then discharged before another patient could come into one of your assigned rooms. You would always have the same room. And again, we would have the 2 nursing staff members assigned specifically to our resident team. There's also half of our clinic is run by a non-academic team, so we share it with them. So the study results, when we look back over EPIC, you see here, we actually had 2 months where we looked at the pre-intervention study. Our total number was 140 patients, 96 were pre-intervention and 44 were post-intervention. In the month of December, we had an average wait time of 60 minutes from when they walked in our door and first registered till they were seen by us. In January, that was 50 minutes. And then post-intervention in February, this was reduced to 12 minutes. This is just a graph representing that. But we can see that there was an absolute improvement here of 38 minutes, a 76% relative improvement in reduction of wait time with just these 2 interventions. Now, unfortunately, the study was terminated quicker than we would have liked. So in the ACT cycle, we had an inability to institute these changes for more than this 1 week. We did meet with the staff and tried to debrief after this first cycle to see what could be fixed, but unfortunately there just wasn't enough support from them and from administration to continue doing this. I think some of the main barriers that we faced were a limited number of staff members. Unfortunately, one of the MAs left the clinic that week when we tried to run our first cycle, and I think that put a lot of strain on the nursing staff themselves, and it just kind of got it off to a bad foot. Even though the data looked great, I think they were under a lot of stress with this. Overall, it's hard to implement these system-wide changes when there's so many people involved. I think there's just a resistance to changing things that have been in place for a long time. And again, like I mentioned, we share this clinic with a non-academic team as well. And I think there may have been some miscommunication between nursing staff and those other practitioners that when we revisited this, we found out about. So we'll try and talk to them a little bit more going forward to see if we can give this one more run. Again, with the data that we had, it was a lot better than we expected, and it's a little bit frustrating to have such great data with such a small study population. There are a lot of future goals with this study. We'd like to revisit it, again, talking with the staff and seeing what we can pinpoint and work through going forward to make it easier on everybody. Going forward, we'd also like to measure the patient satisfaction by having them possibly fill out forms before and after, and then explore ties between this and patient compliance. The registration checkpoints, there's actually 2 points where a patient will register when they come into our clinic, so if we could try to reduce that, that could also help to streamline things. And ultimately increasing our clinic staff, and that's kind of out of our hands, but at the very least trying not to have somebody, leave in the middle of our first cycle, and just getting more support for the staff themselves could help with triaging and getting patients room for us. So in summary, there are studies to back this up that show that decreased wait time does relate to increased satisfaction, follow-up rates, and compliance. And all of that goes a long way in not only helping these patients, but in also cutting down the amount of ER visits we're going to have and getting our patients back into our clinic. I think it's a great service for these patients, and we'd like to make it as easy on them as we possibly can to want to come back. I think assigning the 2 rooms worked well. I think every busy clinic we've been in works this way, instead of just having your patients being scattered throughout the clinic. So I think this was a good process of streamlining it. And another reason we wanted to do it, Jennifer, Samuel, and myself are actually going into outpatient primary care next year. And so we wanted to try and make this a better experience for the residents themselves and for our medical students when they come into our clinic, to where they may be a little bit more inspired to go into primary care. So that was one of the big reasons we wanted to do this. I think the main lesson we learned in this study is just how difficult it can be to try and implement a big change in a big system with so many people involved. So a little frustrating, but these are our references, and I'll take any questions if we have them. Yes.
Did you share your results with the staff and administration?
We've talked to them a little bit. We're actually going to maybe present this to them in our next clinic. I have one more clinic left in UMA, and we want to try and present this to them and see if we can push forward for next year to try and continue this, because I think it is worthwhile. Yes.
Were there any downside to the change? Like, did it create a bottleneck somewhere else in the process?
For us, it was great. I mean, personally, those few days when I was actually working in this system, it went a lot smoother. So for the residents, I think it was fantastic in our flow rate. I think the nurses did have a little bit of an issue with maybe the bottleneck and that the people were in the waiting room. And that's what we need to try and pinpoint with them a little more, as to where that happened and why. But when we looked at the data, just the amount of time that they were coming in and being seen by us, it seemed to be flowing really well. I think there was some miscommunication, but yes.
I was just going to say, there are really a lot of good models of how this did work
Mm-hmm.
in different, other institutions. And I've been here about 4 months, and in one of our outpatient specialty clinics, I had to wait for 2 hours to see someone, and that was a shock to me. I was also shocked that y'all are not actually giving the patients an opportunity to give you feedback about this already. So
Mm-hmm.
that's another opportunity.
Right, and we're going to try and discuss these. I appreciate that. We'll take it into account and talk with the staff next week about all of this. So.
How many residents do you actually have having clinic at the same time? Our clinic, we have 3 to 4 on a given how many are actually seeing patients?
That's what we have, 3 to 4. Depending if somebody takes a vacation, it's up to 4 at a time usually, but 3 to 4 is about the average that we have. Right. Yeah, and again, it was a small population, and we had to adjust the rates because it was terminated quickly. So we don't know if it would continue at that rate if we were to stretch this out for further cycles. Yes.
Dr. Story, I just want to thank you for highlighting, once again, the outpatient practice. You get a lot done, and you have resources to the bottom. If you don't have that, then you're probably not going to have as good patient care, quality outcomes, and patient satisfaction.
Right.
With engaging that system.
Absolutely. All right, thank you.
Dr. Psqi tells me he will be in the system, his next step in his career, so he'll still be here. So very, very good news to hear that. Internal medicine, Dr. Stone is going to talk about the effect of communication training on HCAP scores in an internal medicine training program. Okay.
Let me just get this pulled up and we can get going. All right, so like you said, my name's Yarley Stone. One of the first years in the internal medicine program. For my QI project, I was taking a look at what we could do here on the inpatient side to improve HCAP scores, kind of improve overall patient experience here. So our aim statement was to improve HCAP scores for our personal academic internal medicine service. from the baseline, which we'll go over in a second to see kind of why we brought this up, to the sort of Erlanger goal of the 75th percentile, seeing what we could do by the end of the fiscal year of 2018. The ultimate question that we're looking at is on HCAP scorings, the doctor-related questions, not looking at the nursing one, just the patient satisfaction with physicians. But because that data takes a while to come, I'll also be talking about a process measure we went where we did basically a pre and post survey before we did this implementation and then afterwards to just see how the residents and fellows and the attendings who responded felt about it as well. So these are just going through, these next 3 slides are looking at, for the past 2 years at this point, the HCAP scores and how we've been doing the percentile. The kind of beige bar is the actual percentage score, but the number that we're looking at improving is this line that's tracking along, which is the percentile ranking. This is pulled from the list of attendings who work with our academic team, and you can see that we've had some times where it's been good, but there is it's never hit. It's right here it hit about that, almost at that 75th percentile, but besides that, it's been far below, kind of consistently throughout. Talking about courtesy and respect, again, there's still been loads of room for improvement throughout. And then how how patients feel that we're explaining things to them, we're not on the chart on some of these areas. So there's plenty of room to improve, so that's what we're looking to see if there was an implementation we could do on our side to help with the residents, because the residents actually spend most of the time with the patients, and then the attendings kind of come in and face, but the scores still go under the attendings' names. So looking through kind of previous data and some previous studies and papers, it's been shown that actually patient-reported experience of care can also correlate with the technical measures that we see about how patients are doing and the care that they received. More and more now in medicine, there is this focus. There's a reason why we're doing QI days like this, focusing more and more on patient satisfaction as an actual measure of perception of care, and then getting down to ultimately the bottom line that actually the reimbursement that the hospital receives and kind of the things we're able to do in the long term are also related to that. So that was the background for our issue. I talked about the pre and post survey that we did. Before we implemented this program, about half of people had not received any prior formal communication training, and we'd all been talked about empathy in medical school, but that was about the extent of it. Never really any true discussion about how to talk to patients. People who had it before overwhelmingly found it to be positive in the past. But like I said, about only half of the residents had received anything in the past, so we wanted to kind of standardize this among our program. So we implemented a formal communication training. We took a look into it and worked with administration. Brooke Horn was also very helpful in this as well, in kind of helping us find something that we could implement for us. We wanted to make sure it was a standardized product that had been used elsewhere, that wasn't something that we were just making up as we were going. So we used the language of caring system, which is actually a great system, comes with some interactive lectures, some take-home sort of studies, and then also has a basically year-long access online to go back and review the lectures, review these kind of interactive modules. So if people missed out on one, or if they forgot a little bit, they have the ability to go back and refer to it in the future. So we broke it down and invited all the medicine residents. There's about 30 of us. We also got funding to include the GI and the cardiac fellows, and then the faculty associated. Everybody was welcome to come. Like I mentioned, the program included having online resources available for a full year afterwards, and then we did that pre and post survey, which I'll go over the data here in a second. So for the survey data, at the beginning before we implemented it, we sent out this survey to everybody. It was just 9-question, kind of yes or no, and then finding out what level of training they were at. 24 of the people responded, 17 residents, a couple fellows, and 4 attendings. After the study was done, we did our best to try to match that number again, got back up to 16. So we did have a little drop off in response there, but we did the best we could. So at the very beginning, just looking at, are the residents even familiar with these questions? Do we really understand what's going on here? Before it, less than 40% said, yes, I know these questions, I'm fairly familiar with them. Afterwards, everybody who responded said, yes, now at least I know what this is, I know what they're looking for, and I know what sort of things I'm being graded on. Then getting down to more specifics, all right, if you know what they are, can you actually tell me just one of the 3 things that people ask about the physicians in the HCAP survey, and we had very similar response on this after this, was that before it was less than 40%. Afterwards, everybody who responded said, yes, I can name at least one thing. You know, they asked me if my patients listened to me. Luckily, we didn't have to really teach people this, but everybody came into it already believing that this was important and that this did actually affect outcomes. So we didn't really have to change people's mind frame on this. We just kind of were trying to give them the extra tools in order to improve what they already wanted to do. And then in terms of how people felt personally about what they could do in order for specific techniques, you know, we weren't trying to reinvent the way they were talking to patients. It was just small things. It was, you know, body language things. It was giving everybody a marker so that they could write their name on the whiteboard in the patient's room. That, you know, every room in the Erlanger has one of those boards that, for the most part, just has vitals written on them. And we were trying to implement, no, let's actually write, you know, who the attending is on the team, who the resident on the team, what goals do we have today. Little things like that that take a minute but can actually show success. And we had a huge success, at least on this, in personal reporting, that everybody said, you know, now I know some specific techniques to do. And then, you know, at the beginning, most people felt, I know how to talk to patients. Afterwards, at least everybody who responded said, no, I definitely know how to talk to patients. I know that when I talk, patients are actually hearing me and that they feel like I'm hearing them. So that's at least a good thing to see. And then another topic that was broached in the language of caring curriculum was talking about, you know, difficult news, bad news, be it, you know, mistakes on our end or just, you know, important diagnoses. And we did see an improvement in just how providers felt about being able to have those discussions. And then the ultimate kind of question that we asked at the end was just, all right, now we know everybody here has had this training. Did you find it helpful? Most people did. A couple people said, you know, I've already had this training before. Sure, we could do it again, but I don't really know what to do. But the important thing to remember, I think, is that, you know, over half or almost half had already had training before, and still most people found it helpful to go through again. So looking at our conclusions, so, you know, we did find that, at least for the residents reporting it, that they felt that we had had specific improvements, and they found these sessions to be helpful. You know, our ultimate goal that we're looking at is, can we really influence the HCAP scoring, you know, at least within the academic internal medicine program. I understand that's not really how HCAPS is supposed to be, that it's supposed to be for the whole hospital as a whole, and you're not supposed to divvy up specific programs, but we're trying to see if there's something small we can do on our side, because this program does require some funding in order to get access for all these people. So if we can show some improvement, at least within our kind of, you know, small little group, we can spread that out to the rest of the hospital as well. So we'll hopefully be following up with some more scores there. And then we'll be looking at the HCAP scoring from at least our attendings on our side, and then if we see improvement there, then hopefully being able to talk to administration and see about, all right, let's try to get some of the other programs involved and see if we can kind of keep growing this and get Erlanger to that spot where it says it wants to be. So that's where we are. Sorry, that was kind of fast. Any questions? Yes, ma'am. Used here. So we, that was what actually Brooke Horn was great at helping us out with, was she was able to give us information for the specific attendings that work just with internal medicine and look at, you know, how the scoring response that those attendings had gotten over that time. So it's given the way that, at least for the way that I remember it being, is that they get the questionnaire within 48 hours after being discharged, and then they respond there. You know, we can't make the patients respond to it, but we give them that and respond to it. We didn't look into changing the way that the HCAP scoring itself was recorded. We were looking into doing what we could on our side. So this is purely inpatient. We didn't look at the outpatient. We didn't look at the GCAPs, anything like that. We just kept on the inpatient side to try to keep it relatively the same, because there are different attendings that work for us on the outpatient side in the clinic that Dr. Scory was just talking about. All right, thank you.
Our next speaker is Dr. Ibrahim Abubaker. He's on his way. There you go.
Hello, good morning. My name is Ibrahim Abubakar. I'm one of the second-year internal medicine residents. And please note, I'm the only presenter so far with a cool accent, so that should come for something. This is a project in clinic that we took over starting March 26th. Title is to improve screening, colonoscopy documentation, and referral rates at the UMA clinic. I was the team leader, and my other co-investigators were Dr. Shahid, Dr. Shah, and Dr. Pudar. And our mentor was Dr. Wooten. And then we got a lot of help from Cass Jackson. She was a process improvement consultant. So just to kind of give you a little bit background and introduction, colorectal cancer is still the second largest cause of mortality amongst all cancers in the United States. And this is recent data from 2016. And this is still disappointing given that there's a lot of data to show that usually with appropriate screening, mortality, there's evidence shows that there's decreased incidence of mortality in colorectal cancers. The United States Preventative Service Task Force actually has a grade A recommendation for screening colonoscopy between ages of 50 to 75. And this is usually based on patients with an average risk for colon cancer. The recent recommendation update came out in 2016. The previous one is 2008. The main difference between that and 2016 was the emphasis that was placed on giving patients choices in terms of choosing their screening. And there are multiple options. There's direct visualization. There's one with stool testing and serology testing. So this is the current screening rates that we generated in 2016. Shows that basically in the U.S. This is the average screening rates of 67%, and in Tennessee it's about 66.6%. This is what we generated in baseline screening rates at the UMA clinic, and what we did was actually took the, I think the fourth quarter report from the UMA clinic that actually showed we generated almost 500 patients, and what we basically did was amongst us, we couldn't really go through all the 500 patients, so we randomly selected, and then based on that came up with this screening rates at the UMA clinic. And the interesting thing is that in 1987, the screening rates in the United States was about 35%. So this 3 decades later in a UMA clinic, we seem to be lagging behind. We knew we had a problem, and then so basically try to work to improve the screening rates. This aim statement was to increase the average documentation and referral rates the UMA clinic from a current baseline of 25%. And it was 27% to at least 50% by April 20th, 2018. This was a 5-week project that we initiated. And we also chose the PDSA methodology for our project. And this is how we started. For our plan, we decided to kind of generate this fishbone diagram to try to target where our barriers to low screening rates were. We kind of broke it down into 4. There's the the residents and team factors, and then patients factors, and also technological factors. What we found was that for patient factors, we see a lot of patients in clinic with low literacy rates, and so we don't really expect our patients to come in and ask for to be screened. So, and then for our technological factors, EMR system currently with Epic does not flag patients that need screening, and it's something that we need to work on going forward. Another technological factors that we were struggling with was some of our patients that had screening done in other facilities and it hasn't been updated on our current EMR system. Team factors, nurses, education-wise, nurses are not up to date with screening going forward. And the main one was we think was residents, and it was important because studies have shown actually that targeting the primary care clinician shows improvement in screening rates going forward. So for our residents, in talking to them, what we realized was that their complaint was that they have limited time to see patients, address their health needs, while also trying to remember when to screen and when not to screen. Talking to patients, most patients would tell you that they did not get screened because the doctor or resident did not bring it up during their conversation. So we knew from the get-go where we're going to use our first PDSA cycle to target. So what we came up with was a simple survey. We generated this survey with the help of Ms. Jackson. This is basically how it looked like. We focus more on the question 9 and 10, whereby we ask patients if they're over the age of 50, they will say yes. And then we'll ask them when was the last time they had a colonoscopy, or whether they've done a colonoscopy before. And based on these numbers, this survey was given to patients once they come in by the nurse clerk. And they'll fill it out, and they're allowed to hold it, take it to the room. And once the physician comes in, they're instructed to hand it over to the resident physician, who, based on the answers they give, will choose to immediately put in the referral rate on the computer do it later. So so it took us 5 weeks for just this project. It was just a first cycle of a PDA cycle. And what we noticed based on the data that we generated after the 5 week of intervention was that we ended up generating about 200 patients within that week. And we split them amongst us and manually went on to the EPIC system to make sure that the referrals were put in, and also if it wasn't done, was it documented. And based on the calculation, our post-intervention actually improved significantly from almost 27% to 50%, which is a little bit short of our goal. Relative risk of 1.825% with a relative improvement of 82.5% for the referral rate. What we found out with the documentation rate was also a lot of improvement from about the same 27% to 43.5%. With a relative improvement of 61.7%. Again, it's just a little bit short of our goal, but it told us a very important thing with this is that if we can find a way to jolt residents' memory in terms of when to go in and put in their referral rate, it's definitely going to show some improvement going forward. And for our ACT, there's this saying, quality is continuous, and I think it's important for quality. This is our first quality improvement project. What it showed us is that if we can find a way to remind the residents, they will do a better job in catching up with this referral rate. And this is a last part of our cycle, and basically we had to make a decision whether to adopt this screening, this intervention that we did, either to abandon it or we can just adopt it, change certain things. And like I said, we didn't reach our goal. It was close, but it's not. We noted that this is a paper. We're doing it on a paper, and it's not sustainable. To make it sustainable, we have to find a way to kind of do it electronically. And if we can do that, I think we should be able to reach our goal. And doing a quality improvement project, you should be able to sustain it that way. Even if we're not in clinic, somebody else will come in and build up on it. So our ultimate goal is hopefully to catch up with a colorectal screening rate, hopefully in the same capacity as in the state of Tennessee. But next step of our project will be to implement the next cycle of our PDA cycles. There's also an option on EPIC whereby it will generate quarterly reports for residents. kind of highlight if they're doing good at screening rates, hopefully I improve. And then these are references. Any questions? Yes, I think that would be our next stage. It'll take multiple PDA cycles to get there, but eventually that is our goal. Because if we can get them increase our screening rate, the next thing is find out whether they were actually able to do their colonoscopies or other screening options, and what the results were, and whether if they were not able to do those screening, what are the reasons? What caused them to not be? It could be financial. It could be a lot of things. But yeah. I think going forward, this is something that future residents can also pick up on once we graduate. Yeah. All right. Thank you.
Our next speaker is Dr. Ryan Goldstein, facing the opioid epidemic, the first step.
Good morning. My name is Ryan Goldstein. I'm a third-year internal medicine resident. Our QI project is facing the opioid epidemic, the first step. The lead persons was Jesse Hufstetter, myself, Suraj Patel, and Ryan Ambrosetti. The participants were our attendings in the UMA clinic, Dr. Thomas and Dr. Malikoff and Dr. Wooten. And it was a 5-week QI project timeframe from March 12th to April 13th. Our aim statement was that this project was aimed to increase the percentage of patients with narcotic agreements at the UMA clinic from a baseline of 10% to a goal of 30% in this 5-week period. The stakeholders involved were our attendings, the UMA staff, and the residents and patients involved. A little bit of the background of this problem: the opioid epidemic has rapidly increased since the early 1990s over the past 2 decades. Here in Tennessee alone, in 2016, there are over 1,000 opioid deaths here and over 7,000 non-fatal inpatient opioid overdoses, as well as 13,000 non-fatal opioid doses in Tennessee alone. In the 2016, over half of opioid deaths came from prescribed opioids, so much so that as of last year, this was the FDA's greatest concern and declared a public health emergency as of October of 2017. And as a teaching facility, prescribing habits in the resident clinic is of utmost concern as they set the foundation of a future and a career in medicine. Preventing or stopping the non-medical use of these prescription drugs is very important to our patient care, and we understand that certain patients benefit from these stimulants, sedatives, or opioid pain relievers, and therefore we need to balance the legitimate medical needs of these patients with the potential risks that they may incur. So the first step for us was to critically evaluate and fully document the scope of this problem. Patients requiring narcotics typically shop at different clinics, different counties and states to obtain these narcotics, so we must remain pretty vigilant in prescribing these opioid medications. Before any narcotics can be written, an agreement must be signed. Upon review of these patients' current narcotic prescriptions, we only had 10% of our patients that had active agreements. Our goal was to change the percentage of these patients with narcotic agreements from 10 to 30%. This was obtained by chart review and utilizing the EPIC report creator to query. We looked at all UMA patients who were only assigned to us as residents, and these medications prescribed below as well. All patients who got medications from other providers, those are under hospice or under palliative care, were excluded. A stepwise how-to was placed around all the computer stations within our clinic to guide residents and staff on how to fill out these agreements. We educated our residents on which narcotics needed agreement and their appropriate use of narcotics. We looked over a 5-week course of patients seen in the UMA. We sent emails out to each of the residents that were going to be in the clinic that week to remind them to fill out these agreements accordingly. We pre-screened all our patients coming into our clinic for a 5-week time frame for all those who needed narcotic agreements. And after the 5-week time period for data collection, we curated the patients seen for the residents in that time frame and then recalculated the percentage of patients who had new narcotic agreements. While the standard of care is that all opiates can only be written if there's an active agreement, it is up to the provider alone to ensure that these agreements are active. Currently, there's no standardized form or practice for how these agreements are actually made, which is unfortunate. So we implemented in our QI project to change the standard in our narcotic agreements, and we were quite effective in our intervention in increasing the narcotic agreements over the next 5 weeks. As you can see on the left, the pre-intervention group was the 10%, and in post-intervention, after a 5-week time period, it was raised to about 70%. We were able to achieve our aim from our baseline of 10% to our goal of 75%, well above our initial 30%. The absolute change was about 65%, and the relative change in our post-intervention was 650%. Our sample size in our group in the pre-intervention phase was 250 and 100 in the post-intervention group. That could just be the kind of the back and flow of just of who comes into our clinics. And we were, in that time period, we were able to see a 48% reduction in patients seeking narcotics since the agreement began. Our goal, considerations for future improvement, as this was just the first round of our PDS cycle, was to make sure that all narcotic agreements are scanned into Epic and put in a separate folder, as well as we recognized later on that not all the narcotic agreements that were signed were actually put into the system as well. We think that in our next round, if we were to do this, that we would like at least an Epic prompt for all new patients without agreements, or even patients with current agreements, to make sure that we are all on the same page, as well as better education on our nursing staff when we obtain these medication lists. In the future, we want to try to do a more extensive inquiry to assess the continued compliance, as this is really important, especially as the opioid epidemic is so important to all our communities and affects all our patient population. Thank you so much.
I'd like to ask our next speaker, Dr. Alexander Trousseau, to come. He is presenting osteoporosis screening in the UMA clinic.
You're welcome.
That's it. Okay. Thank you.
Thank you. I'm a third-year internal medicine resident, and I'm going to talk about our project. We were aiming to increase osteoporosis screening rate with the DEXA scans for eligible patients from current 48% to 60%. That was our primary goal, and the secondary goal was increase percentage of residents who feel familiar with current evidence-based osteoporosis guidelines and percentage of correct answers on online quiz to greater than 80%. We aim to get it done by May 2018. Our project was conducted on Dodson UMA Clinic, which is a primary outpatient site for internal medicine residents. Patients and residents were affected. We started our project in November 2017. There are our key members and our faculty members. Current situation, osteoporosis is a common condition with enormous burdens for patients and society. 50 million of Americans suffer from osteoporosis or osteopenia. The cost of the treatment of osteoporotic fractures is tremendous at $20 billion per year. U.S. Preventive Service Task Force and National Osteoporosis Foundation recommend routine screening for women age 65 or older with DEXA scans, the preferred screening test and the best predictor of fracture. Despite these recommendations based on studies, osteoporosis screening in primary care remains slow at 56%. In our clinic, it was 48%. outcome measures were ratio of actual DEXA result to the number of eligible patients, tracked on a monthly basis, and also percentage of residents who feel familiar with osteoporosis guidelines and percentage of correct answers on online quiz. We used monthly ratio of ordered DEXAs scan to the number of eligible patients for screening as a process measure to see if it transitions in outcome. And we used monthly ratio of colonoscopy referrals to the number of eligible for screening patient as a balancing measure. Inclusion criteria: females age 65 to 79 without reported DEXA scans who actually had office appointment during period from November 17 through April 18. We excluded patients who had DEXA ordered by any providers other than residents. We reviewed all eligible patients in EPIC looking for DEXA results and orders for DEXA. We also checked for prior DEXA results in alt EMR and larger POX. From May to November 2017, 123 out of 257 eligible patients had DEXA results, and the screen rate was 48%. Using PDSA quality improvement methodology, our team identified potential causes for current suboptimal screening rate and identify ways to improve it. Primarily, we were targeting patients, providers, and process-specific causes, specifically knowledge and awareness of the problem in patients and providers, and clinic workflow. We performed 2 PDSA cycles. Cycle number 1 was from November 17 through January 2018. All of the residents received 1 email reminder with a list of eligible patients for screening during one of their ambulatory rotation weeks. We also sent emails with learning materials and articles to educate. And we placed colored screen algorithms in a resident working room. And in our PDSA cycle 2, from January to May 2018, we also placed colorful informative posters in every exam room. That's on the right side. There's algorithm in the resident workroom, helping residents to identify patients for screening. And on the left side of the poster, aiming to increase awareness in patients and serve as a visual reminder for residents during encounter as well. On the upper side of the slide, we have a run chart for our osteoporosis screening on a monthly basis. So base level screen was 48% for 6 months before we started our project. We started in November, and in 3 months we seen improvement, absolute improvement of 4% to 52%. We've seen some lag in the process measure, which is orders of DEXA scan by residents initially, but then it's kind of start picking up. Residents start ordering more of these tests. We were not satisfied with our goal at that time, and we decided to move to cycle 2 when we placed these posters in every exam room, and that's resulted in increase in screening rate to 61.5% in the end of our project. We've seen increase in the process measure as well. And on the bottom of the screen, we were tracking also colonoscopy screening and UMA as a balancing measure to see that, make sure that we are not affecting other important healthcare metrics like colonoscopy referrals, and we see that the screen rate of colonoscopy is improving. We assessed residents' knowledge of screening recommendations. We conducted online questionnaire at the beginning and the end of the QI project, and the percent of residents who felt familiar or somewhat familiar increased at the end of the project from 69 to 83%, and percentage of correct answers also increased from 60 to 65% on online quiz. Follow-up and barriers. At the end of the project, we reached our goal for osteoporosis screen at 61.5%. Probably more time needed to see the persistence of achieved results with the current interventions. Some of the DEXA reports, which were done before EPIC, are not readily available in one place in EMR, but could be found in Erlanger packs. There is a potential for creation for automatic alerts in EPIC for patients who meet criteria for screen, but it can cause alert desensitization and fatigue in providers. It seems that working with the multiple different drivers of osteoporosis screening through PDSA cycles should help maintain or improve our goal in the future. Involvement of nursing staff should be beneficial, and probably provider and process-specific drivers seem to be the most promising. In summary, targeting residents and patients' osteoporosis awareness and knowledge by email, distributing learning materials, email reminders with the list of eligible for screening patients, informative posters for residents and patients resulted in increase of screening rate from 48 to 61.5%. Residents' familiarity with the subject was objectively assessed and increased from 69 to 83%. Knowledge of current guidelines also increased, but not significantly. And thinking globally about preventive screening in primary care, we think that more systematic approach probably needed, and creation of uniform standardized approach to preventive screening, including osteoporosis, via allocation of mandatory for review and update either by provider or nurse preventive health section in EMR with a hard stop before chart signing during each patient visit may be effective system solution for preventive screening in primary care. That's our probably future plan. That's my references. Thank you. Any questions? Thank you.
Dr. Megan Doyle-McClam will present Redefining DNR.
Good morning. My name is Megan Doyle-McClam. I'm an internal medicine second-year resident, and I will be presenting Redefining DNR. So our aim statement is to improve medical professionals' understanding of code status through educational discussions taking place over 4 months, measured with pre- and post-education online surveys. We completed this month. Our stakeholders impacted were our patients, hospital staff, and the physicians. Our team information, we started in April of last year and completed May of this year. Our lead was Dr. Wooten, and key participants included myself and Gregory Heath, who was the helped us with our stats. So the current problem, code status is not always addressed in hospitalized patients. And this project really took place prior to our EPIC EMR system, when the codes were filled out by, or the code status form was filled out by physicians on paper. The form had various check boxes that allowed patients to essentially pick and choose what interventions they wanted. This practice was problematic when such choices as do not intubate but okay for CPR and shock were checked, chemical codes, things that didn't really make sense, and obviously the patient didn't understand what the different code statuses meant and what they wanted. So because of these glaring discrepancies that we kept seeing multiple times, we set out to determine healthcare providers' understanding of code status. This was the initial form, if y'all remember having it, and really choice B, the limited resuscitation, was the main issue that we had. They were able to really pick and choose what they didn't want, but a lot of times it just didn't make sense, only wanting chemical codes, and then if you actually talk to a patient and they had just no idea what that really meant. Or, if you said you want chest compressions and shock, but you don't want to be intubated. Those things kind of go hand in hand, and they had no idea that they had to make those decisions. We were able to change the form after some of our education and going through this. So this was the form that we got it changed to right before we actually changed to the EMR with Epic, and now it's all online. So our goal was to survey providers to determine the general understanding of code status, which was conducted late April of 2017. There was group education led by Dr. Wooten for the next 4 months. She had some grand rounds, and then also just individual group education, specifically with internal medicine. We sent the same survey before and after the education. Most recently was in May, so a couple weeks ago, to assess the differences in understanding after the education. And I will say that during the midst of our project, we did have that switch from paper to electronic code status forms. So there are much less discrepancies in code status because you don't have the option in Epic to kind of pick and choose like you did before on that initial form. This was our PDSA cycle. We've only had one cycle, so our plan was to determine the general knowledge of what code status means to practitioners via the online surveys. Then we had the education to hospital employees, and we also changed the code status form prior to changing to the new EMR. We reviewed and compared the pre- and post-education answers, which we'll go over next. And then we'll continue education on code status, and at least now with the new Epic EMR records, the code status forms are less confusing, and it's not as much of an issue. So the data we collected, the pre-education survey had 66 responses, post-education 46. The survey was a total of 6 questions sent out to the residents and attending physicians. So this is just kind of an idea of who answered. So it's the proportion of physicians by level of training status total pre and post respondents. So we did have a few medical students, and a majority of the physicians answering were senior residents, fellows, and attendings. So of the 6 questions, only 2 were statistically significant. So I'll just briefly go through all the 6 questions, but it's just interesting to see the answers that we had. So the first question was patients who are DNR should not be transferred to the ICU. Most people knew that this was a false statement, so there was not a significant change in that question. Question 2, we did have significant change. The p-value was 0.034 on patients who are DNR should not be intubated. Prior to our education, it was pretty much 50-50 on yes or no, or true or false. And then after education, I think we were able to get across that DNR doesn't necessarily mean DNI, and that is something that needs to be discussed with the patient, because a lot of times things just kind of get grouped together. Our third question was patients who are DNR should not be started on vasopressors for septic shock. No statistical difference in this question. Pretty much everyone answered false. The fourth question was our only other question that had statistical value. So a DNR order applies only in the setting of cardiac arrest and should not affect a patient's care otherwise. So the p-value was 0.015. And after intervention, more people said true, which was good, because a lot of times we have to provide the information for patients. So if a lot of patients, if you actually talk to them about code status, are scared to change to DNR because they think that means comfort care. They get confused, DNR and comfort care. They're afraid they won't get treatment, but DNR only applies in a cardiac arrest. Question 5, a patient with advanced COPD states she would never want to be intubated under any circumstance. Which code status should be recommended? This one was a little bit confusing for people. Obviously, no one picked comfort care because that's not what she wanted, but this also had no statistical difference. And it looked like maybe even a little bit more confusion after intervention. And our last question was essentially what a chemical code means. A, give epi during cardiac arrest without compressions. B, I'm not sure. And C, I'm not sure. Partial code status orders are confusing to patients, providers, and families and should not be used. So you can see pre and post intervention, much more people answered C. Not sure, it's confusing, and shouldn't be used, but no statistic difference. So some of the barriers for our project, there's really no way to determine if code status is discussed with each patient. We just assume that when we admit patients to the hospital, we're having that discussion. Hopefully a discussion starts prior to being hospitalized and they already have a decision made before they come. Pre and post education surveys had different response rates, and those responding had different postgraduate levels. So in summary, there were some statistically significant changes in pre and post education surveys, such as knowing that a DNR only applies in the setting of cardiac arrest, and DNR not also automatically mean DNI. And then with the change in the code status form, and now with our new EMR with Epic, the cherry picking code status is not really an issue anymore. Possible next steps are requiring the post form, which is the physician order for scope of treatment for nursing home patients. This is a legal form in the state of Tennessee that can follow the patient no matter what hospital they go to in Tennessee. Code status pamphlets available to patients and their families, kind of describing what each code status means and entails. And then continued education for medical providers on what each code status means, as there continues to be some confusion from residents all the way up to attendings based on our answers that we got. And that's it.
Dr. Stephen Russo will speak about Go Forth and Refer.
Morning, everyone. My name is Stephen Russo. I'm a second-year internal medicine resident. I just want to thank all of you for being here, too, and spending your morning with us. Title of our project is Go Forth and Refer, so that's what we're going to tell you to do today. And as you can see, it's an acronym for GFR here. Worked on this project with Dr. Bond, Srinath, and Verma, and our attendings that helped us was Dr. Thomas, Malikoff, and Dr. Wooten. Now, our goal for this project, you know, a lot of people know about screening for colonoscopy, breast cancer, sending for mammograms, but everyone forgets about the kidneys. So, you know, kidneys are directly affected by hypertension, diabetes, and a variety of other diseases. So our goal was in our primary care clinic at Dotson Avenue to refer our patients to nephrology with a CKD stage 3 or worse and improve that percentage by 25%. Our goal was to do that by this month, and we started in January of 2018. Some of the other people impacted aside from ourselves at our clinic are obviously, most importantly, our patients and nephrology associates here based in Chattanooga who also practice at Erlanger Hospital. Again, these are our people who were involved, and our start date was January of 18. Now, what's the current dilemma? As I was saying, hypertension, diabetes, all of these things can contribute to chronic kidney disease. It often goes undetected. It comes up on your metabolic panel, that little number there that's maybe in red that no one pays as much attention to until you're worried about prescribing drugs or you're not very keeping a close eye on it. So it often goes underdiagnosed or even undetected until the disease becomes well advanced, and we see some of the other repercussions of this. So the importance is early recognition by the physician as well as timely referral to nephrology, which helps prevent the progression and complication, which is evidence proven. This timely referral reduces mortality and morbidity. It helps patients from going on hemodialysis, as you can see, delaying or preventing the progression of renal failure. And initially, our referral rate was only 37%. So what did we want to do? Like I stated in our aim, we wanted to increase our referral rate by 25%. To start off with this, we started with one of the lower level things in terms of quality improvement projects, starting with education of the resident physicians. And we did this through first PowerPoint presentations sent out to the residents, as well as later on in PDSA Step 2, we wound up doing illustrative posters in the clinic as well. Now, as part of our planning cycle here, we focus on the education of the resident physicians of the importance of the nephrology referrals via PowerPoint. A sampling methodology was determined. Actually, Dr. Bond helped us out with this in filtering out on EPIC, checking on patients from July of 17 to December of 2017. And this was determined from inclusion criteria of a GFR underneath 60 on the most recent BMP. Now, this came up with a total of 190 patients, which we divided amongst ourselves, and we checked these patients to confirm that it was actually CKD, because in AKI you'll see a decreased GFR, which isn't accurate. So we had to do some combing through the data there to actually find out if these patients were truly CKD, which is how we came up with the 37%. Now, at this point, we decided to implement the PowerPoint that was developed and emailed to all the residents, and we monitored this from January to April of 2018. So some of the problems with this in our quality improvements project was we don't have read receipts on our emails. Did all the residents even see the emails? Our inboxes get flooded with things on a daily basis. And if they did receive the email, did they actually download it to look at it? And also on a day-to-day basis, we all have other things going on. Sometimes we forget about little things that go on and may not remember to check the GFR in a patient at that clinic visit. So as part of our study portion, we ran the same search again as we did before, the same algorithm on those patients from January from 2018 to April of 2018. And that resulted in 7 out of 16 patients appropriately referred to nephrology, which increased the referral rate to 43.75%. However, that was not a significant improvement as we had wanted since the initiation of the QI project. So we acted again. So PDSA 2 was we needed something to serve as a reminder to our project without being too intrusive or annoying. We all see in EPIC we have our alerts that pop up that tell us one thing or another. Alarm fatigue occurs, and sometimes people may not do this. So what we decided to go with were educational posters placed on the continuity clinic's walls and at the workstations where the residents are. This is our poster that we put. Nice, bright, colorful cartoons to attract the attention of your well-educated doctor. And also, again, emphasizing the importance of early referral and what the inclusion criteria and exclusion criteria of our practices were. And as you can see, we also excluded ESRD in our patients who are already on hemodialysis, as well as transplant patients. Now, this is some documentation in terms of our improvement. As I was saying before, we were only at 37% when we started our study and able to increase to 43.75. By cycle 2 is where we introduced the educational posters, and unfortunately that was only done in April. So since that point in time, examining the data, there's only been 2 patients who have qualified by our criteria, but half of them have been referred. When you're looking at the absolute improvement, the first cycle of almost 7%, whereas the second cycle was about 13%. However, the most important number is the relative improvement to 35% of after the second cycle was implemented over the initial data. Now, what is some barriers, some follow-up issues that concern us with this project here? Our clinic staff has to set up the nephrology appointment, and since the nephrology associates group is not on EPIC with us as well, we can't see what time, date the appointment is. If the patient actually did follow up with the nephrologist based on our referral here, so we have to depend on them being able to send records via fax to us so they could actually be uploaded to EPIC and follow through on that. Some considerations were, again, contacting someone at EPIC to set up automatic prompts or alerts for a patient who meets criteria of our project. The concern there, again, is alarm fatigue and just wind up another click added to the bundle there. So what is our next step in this project? We do need to reassess the referral rate. As we can see, it's gone up and we're approaching our goal. However, it is a small sample size, so we have to take that into consideration as well, and as time goes on, re-emphasize this to our residents. I think if we find that we are unsuccessful, education, we need to redetermine of how we're going to go about this. Again, in terms of QI projects, education is kind of the lowest fruit on the tree here, so we may need to find some other action to go through there. One of the ideas we had was color coding the BMP. As of right now, an abnormal GFR only comes up as a red color. Maybe even color coding different CKD category GFRs may be able to help our residents in terms of alerting them to this and proper referral. So in summary, we're trying to improve our referral rate to 50%, which we actually did. We'll need more time and a bigger sample size to go through, and I imagine another PDSA cycle just to determine how we're going to, again, re-engage the residents as well. but we did have a relative improvement of 35%. And recognition of the physicians of the GFR and CKD3 or higher is the biggest barrier to overcome. These are some of the references that emphasize the importance of referring patients to nephrology early on. I'll take any questions.
We are now at our break time. I'd like to give you just a few minutes to stretch your legs, get some bottled water outside in the hallway, and we will resume promptly at 10:40. Yes, 10:40. We will start or complete our pediatric presentations, and then our final one that's a combined nursing and surgery presentation. So see you back, and we'll be ready to go right at 20 of the hour. Thank you so much. Yes. Yes, sir.
So is there going to be one winner for second?
I'm just wondering, okay, that's it, but then maybe the coordinator now, you know, so I need to see.
Because I don't want that to be a barrier for, you know, them trying to.
Yeah, very good. Thank you.
Thank you.
I've been drinking water. That's good for you. I've heard.
I just need to stand up.
I know. Because I was not part of the discussion.
The sister-in-law, the mother. Yeah. Yeah, the sister-in-law is where she found the mass. Her, my mom is 78. A year old. Yeah. Well, that's right. That's right. So, and mom didn't get hurt in the fall. She has bad arthritis in her knees, and it's just got worse. She's just kind of deconditioned now.
Thank you for coming back so promptly. Our next speaker is Dr. Michael Fasciolo, and he will be presenting increasing rate of fluoride varnish in a general pediatrics clinic. Thank you.
I'm Dr. Fasciolo, one of the pediatric interns, and my mentor for this project is Dr. Garcia, who's here in the back today. We're increasing the rate of fluoride varnish in our Gen Peds clinic. So we start off with our aim statement to increase the rate in patients 1 to 5 years old that have teeth and don't have a dental home in our clinic by 25% from whatever the current rate was, which was unknown at the time. A little bit of background on why this matters. Caries are the most common chronic disease of U.S. children, and the prevalence of this disease has been increasing. Toothache in 2008 prompted over 15,000 visits to pediatric emergency departments in the U.S. alone, and fluoride varnish helps prevent these caries, 33% reduction in primary teeth and 46% in permanent teeth. Additionally, the number needed to treat is nice and low for this intervention, 3.7 children in low caries communities, and in a community like ours, which is called a high caries community, only 1.6 children. Fluoride varnish has undergone several different revisions as far as recommendations for it go. In North Carolina, they had a state initiative called Into the Mouths of Babes in the year 2000 that the North Carolina Medicaid did a bundle of $50 paid for a dental visit as part of a well-child visit. So this included a dental assessment, fluoride varnish, and they also did some dental sealant in that study, which we did not do in ours. They got good results from it, so the U.S. Preventive Services Task Force picked it up in 2004, and they didn't do a fluoride varnish recommendation, but said if fluoride is not readily available in the water supply, then you should do fluoride supplementation. In 2013, the American Academy of Pediatrics said, let's do this every 3 to 6 months, starting from tooth emergence. Let's give these kids fluoride varnish. And then in 2014, USPSTF picked up that recommendation as well, and that is the current recommendation. So in our study, we included patients between 12 and 60 months, which is 1 to 5 years, without a dental home, with tooth emergence, even if it's just 2 little teeth, and who didn't have fluoride varnish applied in the previous 6 months. And our only exclusion criteria was parents saying no. So getting into our cycles, our first cycle was to figure out where we are. What are our barriers? What's going on right now? And what can we do about it? So we did a chart search over 2 months for these patients. We had 92 patients that met criteria, 89 that weren't excluded, so basically 3 parents said no, and fluoride was applied 6 times, which is 7% application rate, which is not great. So what are those barriers? The circled barriers are the ones that we did something about with this intervention. So we had residents forgetting, we have nursing staff coming as turnover. Our materials are scattered all over the place, and there's a lot of materials not included in the room that we had to go around and find. So that was what we wanted to address with this intervention. We basically found what would be the easiest and what would bundle the most barriers together. So this intervention was to get all the materials together, put them at the nurse's station, and then we were going to review how we were going at that point. So this is what it looked like. All the materials gathered together, a bilingual post-varnish handout on the side over here. Over this 2-month section, we kept the 89 constant throughout all of our progress assessments. This time we had 17 actual applications, which is a rate of 19%. So we went from 7 to 19. That's great. That's 12% absolute change, a little over 270 relative change, but our goal was 25. So we need to do something else. We're still not there. What else should we do? So we analyzed barriers again by doing a survey of the team members, the residents, nursing staff, clinic providers, and found that we're still forgetting both the residents and the nurses. The residents are having to do this criteria assessment, and is this intervention even being done? We're not sure. So now we're going to move the materials into the room beside the sink and do actual process measures to make sure our intervention is being carried out, and then continue to review our data as we come back. So now we move everything over to the sink, and hey, look, we're going up. 25 out of 89, which is 28%. So now from our intervention 1 to this intervention, we've gone up another 9%, 21% from the initial state, which is a relative increase from initial of over 4-fold and a 1.5 times increase from the previous one. So let's measure the process and make sure we're doing everything that we want to be doing. Our goal, we hit our goal at this point. Our goal was 25%, so we're at the goal, but we want to balance our intervention to make sure that it's able to be carried out long term. So we're still having some forgetfulness. We're still wondering if our intervention is being done. And now that the fluoride varnish materials are in the room, if I am there as the patient and my sister is there and she touches it, and then my mom says no, I have to throw that away. Lost materials that aren't being used is not good when you're running on narrow margins for cost savings. So being discarded if it got touched was a big problem for that. So we analyzed this process. Were the fluoride varnish materials at the nurse's station? In January and February, all the time they were there. So that was an obvious change in process. Were they beside the sink in the exam room? Not really. It was forgotten a lot. So we need to change the process, balance it, and figure out why it's not being carried out the rate that we want it to be. Which brought us to cycle 4. Now we have the materials inside the letterbox leading into the room. So they're not in the rooms, they don't get contaminated, and they still are in the field of view of the residents and the rest of the staff. So there they are, right beside our room. Now, of the 89 not excluded patients, we have 34 fluoride varnish applications, which is even better. So we went from 28 to 38, another 10% increase, where over 5.5 times our initial rate and another over about a third increase from the previous rate, which is, I mean, we're doing a great job here, I think. So our materials are still at the nurse's station. They are no longer in the sink, so that was a successful discontinuation of intervention 2. And they're up 10% from intervention 2 to actually put them in the letterbox. So we're following that process change better than we were following the previous process change. So intervention 3 is often being performed, and we successfully stopped intervention 2. So let's recap. We've talked about a lot of numbers. The dark black line here is our goal of 25%. So we started at 7, terrible. Moved materials to the nurse's station, went to 19, pretty good. Moved it to the sink, 28, hey, we did it. But let's balance the process. Now we're at 38, well past our goal. And I think our clinic is doing a great job here. So our aim has been achieved. We measured the process throughout the interventions to make sure we're actually doing the intervention that we set out to do. We balanced essentially nursing time and resident time were the two big competing factors that needed to get balanced. We surveyed residents and the clinical staff after each intervention to see what the barriers were moving forward. This intervention is sustainable, so our reimbursement is greater than the cost of fluoride varnish materials as long as we're not wasting materials like we were for a brief time. And overall, it's cost savings to the healthcare system because, like we talked about in the beginning, we're cutting down the amount of toothache presenting to the emergency department. We're decreasing the dental burden of caries to the community. Our current barriers are still that we have staff turnover. Every July 1st, we get new residents, for example. So having full provider engagement as well as having ongoing turnover leads to the missed opportunities that we're still sort of seeing. Things that we're thinking about doing in the future are to get our actual clinical staff to be able to do this. So once we're fully staffed and in our new space, seeing how we're going to transition to that and get the clinical staff to be able to do this as well. And then one of the next steps we want to do is to analyze the actual community impact. We talked about the number needed to treat. We talked about the incidence of this problem. So what difference is our clinic making? We have numbers, so we have theoretical difference, but let's examine it and see what we're actually doing. What questions do we have? No? Okay, thank you very much.
Our next presenter is Dr. Rachel Kielman. She is presenting the introduction of spirometry testing in the Vance Stafford General Pediatric Clinic in children aged greater than 5 years old with a diagnosis of asthma. I'll get it up for you, okay? There you go.
All right, good morning, everyone. Like she said, I am Rachel Kielman, one of the pediatric second years, and this is our pediatric quality improvement presentation of the introduction of spirometry to our general Vance Stafford Pediatrics Clinic in asthmatic patients. This project was jointly done with resident doctors Hannah Cox, Nicholas Webster, Jack Whitehead, with faculty advisors of Carla Garcia and Julia Katsura. Our project basics include our aim, which wanted to be an increase of percentage of spirometry testing from 0 to 50% by May 2018 for patients 5 years of age and older with a diagnosis of asthma. This was done, of course, in our Vance Stafford Pediatrics Clinic, and it was done from October 2017 to May 2018. So why should we care about asthma? Asthma holds a significant burden in our state as well as our country. It's the third leading cause of pediatric hospitalizations nationwide. Controlling asthma and managing it in the primary care setting can save on ER visits, hospital visits, missed day of school for kids, and missed days of work for parents. On average, our children with asthma miss 2.48 more days of school per year than those without asthma, and annually spent throughout the year $56 million on asthma management as well as exacerbation-related costs. Our clinic is a partner of the Tennessee American Academy of Pediatrics Pediatric Healthcare Improvement Initiative for Tennessee. This is in regards to asthma management. That focuses on asthma education, asthma control tests, severity documentation, and action plans. And until this year, asthma spirometry introduction was not available. And we had to send our patients to either a specialist, as in pulmonology or allergy. The AAP recommends spirometry testing at the onset of diagnosis of asthma and then annually at well-child checks. And so what is spirometry? It's actually a test that is used to assess how well your lungs work by measuring how much you inhale, how much you exhale as in forced vital capacity, and how quickly you exhale as in forced expiratory volume. The patient, you can see here, they take a deep breath and breathe out as hard as they can for several seconds into the tube of the spirometer. So we've showed kind of 3 different devices here. And this is done at least 3 times to ensure that you have a valid result and they're consistent as well. So we tried to look at what we needed to accomplish our study, because spirometry is generally a safe and easy thing to do in the primary care setting. So we looked at our people first. We have 24 residents with only 1 half-day experience in our clinic, as well as preceptors with only 1 full day per week of clinic, and then full-time nursing staff. The environment was our pediatrics clinic. We looked at our resources, which was the spirometer and the cost to obtain it, and then our process was spirometry education, identifying our patients accurately who met criteria, proper EPIC documentation, and then creating kind of quick reference guides or cheat sheets in regards to asthma and spirometry documentation. To do this, we had a couple different measures. We had our process measure was the number of patients correctly identified that met criteria for spirometry. Our outcome measure was the percentage of charts with proper documentation of yearly spirometry performed. And our balance measure was the time to educate staff, as in residents, nursing, and physicians, and then assess our triage time, physician visit time, and the cost to obtain our spirometer. Our full PDSA plan had a couple different cycles. We had 3 in total. Our first one overall was spirometry education, and then our second was a very tiny trial run of spirometry implementation, and the final was full, complete introduction of spirometry into our clinic. So our first PDSA cycle, this was our education cycle. So what we did, we had a 30-minute lecture, educational lecture for residents, and then we also had a 30-minute hands-on spirometry workshop, and we also had a lecture just for our full-time staff on spirometry done by a respiratory therapist. And then we as well had our quick reference guides that we projected into clinic, and emailed to everyone as well. So here you can see 20 out of 24 residents completed their training, and 100% of our full-time staff received their one-on-one training. So due to that little error that we had 4 residents who didn't receive their training, they were notified and they were given the PowerPoint cheat sheets and PEDS in review articles by email. So this is one of our cheat sheets that we're showing you here. Up here is a healthy spirometry curve, and then something that's more ideal to our specific study is the obstructive one where our asthmatics might lie, and then you can also find cystic fibrosis and bronchiectasis, and for our adult counterparts, COPD. We also posted restrictive curves, so you might see that in neuromuscular disease, as we have some patients with muscular dystrophy in our clinic, and you can also find this in ALS or sarcoidosis. And then we also showed vocal cord dysfunction, where here you can see kind of a lag on the inspiratory curve at the bottom. This was another one of our quick reference guides, mainly important to those of our staff completing this spirometry. So you can see at the top, you have to have 3 or more good curves to say that it's a valid test, and then you have to have a repeatable FVC and FEV1. And then if you didn't get those repeatable curves to make it valid, there were some kind of examples down below to show you what might be needed to make the testing better. So for this one, it's like a poor initial blast, so tell the patient to breathe harder. For this one, you can see the curve dips a little bit, so the patient likely coughed in that area. You can also see them with taking extra breaths, as you can see these little jumps. So we posted that just to make sure that everyone could be on board and make sure we had the most valid test results possible. Our second PDSA cycle was the small implementation of spirometry. This was where we conducted 1 spirometry testing per day on clinics during the month of December 2018. And with that, we identified and completed 100% of spirometry on the patients who met inclusion criteria, and in total that was 6 patients. So with that good percentage, we decided to forge ahead full force to doing full spirometry implementation. This was another one of our spirometry quick reference guides. This was mainly for our staff to look at the day prior to our patients coming to clinic. You see on this algorithm, they decided whether the patient had a diagnosis of asthma, was coming for a follow-up visit, or was a well-child visit with a diagnosis of asthma. And then at that point, they decided who was managing their asthma, so either us at UT Pediatrics or the pulmonology and allergy clinic, and then if they had had spirometry within the past year. And if they had not, so they would mark them with a red dot, and we would know that the next day they needed spirometry. Our final cycle is the full implementation cycle, and with that, we had 23% of patients who met inclusion criteria receive their spirometry testing, and so with that percentage, we began to identify our barriers to spirometry testing. But before we get there, we have our official results page. So just to kind of orient us here, our Erlanger aggregate is that in the darker royal blue. The lighter blue is the state aggregate. So you can see before our spirometry and quality improvement project, we remained well below the state aggregate. But this right here is about our onset of the project. And you can see as of January, we just kind of skyrocketed with our quality improvement. And that made us above the state aggregate to 23.1% of identified patients receiving their spirometry testing annually, where the state aggregate was only 15%. So with that, the barriers to our study, we thought there was a little bit of confusion in data entry into the FIT website. So sometimes there was spirometry actually done, but it might not have been documented in the chart, although it was scanned in. So analyzing how to kind of coordinate both of those. We as well had a good deal of nursing turnover in our clinic and retraining of both nursing and residents. And then difficulty on proper documentation once spirometry was actually done, because as we stated before, residents and attendings don't always get experience to the asthma plus spirometry at every well-child check, so ingraining that with repetition was difficult. So overall, for our summary, spirometry was made available, which was not available until this year. Our staffing was overall better educated on spirometry and asthma management, and 23% received spirometry in our clinic, which was well above the state aggregate. And our project is ongoing, so we're seeking those barriers that we just talked about to reach over them and eventually get to our goal of 50%. Any questions?
wish our two clear surveyors could have been here today. That would have been very handy. Next presentation from Pediatrics, Dr. Sherian, Depression and Anxiety Screening in Cystic Fibrosis Patients.
My name is Christy Cherian. I'm one of the third-year pediatric residents. My QI project is depression and anxiety screening in cystic fibrosis patients. This project was made possible by my mentor, Dr. Ledbetter, and Dr. Kreth, Katie Wilson, and Melissa Moser. So the aim of my project is for 90% of our patients with cystic fibrosis, ages 12 and older, seen at our pediatric pulmonary clinic, to be screened for depression and anxiety using the PHQ-9 and GAD-7 screening questionnaire by September 30th, 2017, and appropriately referred for intervention if necessary. So we were not consistently or routinely screening for depression in our CF patients as recommended by the CF guidelines from 2016. We were only screening about 8% of our patients for depression prior to this. The International Depression Epidemiological Study, or the TIDE study, is a study that was done that screened over 6,000 CF patients ages 12 and older and over 4,000 of their parents. And this was done in over 9 countries, and it showed that depression and anxiety are 2 to 3 times more prevalent in patients and their parents. So some of the process measures: percent patients screened, the percent of patients with a positive screen that were appropriately referred for supportive, psychological, and or psychopharmacological interventions. And the balancing measures included increased time required for patients to fill out the screening questionnaire, refusal of patient to fill out the questionnaire, and increased time for our staff, specifically our social worker, to score the screen. So for the first PDSA cycle, we were training the staff on when and whom to administer the screen, how to score the test, and where to document the results. Then administered the PHQ-9 and GAD-7 screening questionnaire annually at the beginning of the CF clinic visit as per CF recommendations. And then review the number of patients who completed the screens and study those trends of completion. And then we did a mid-year assessment on how well we were screening to see and use those results of analysis to see if we needed to have any more improvement in the overall process. For my second PDSA cycle, through the duration of the study, or through the duration of the project, we charted patient scores and referral history. Then calculated the percentage of patients with a positive screen that were appropriately referred for psychological and or psychopharmacological interventions. And then at the end of that, we, with the data obtained, created graphs to study trends of completion. And in the end, for those patients who had not been screened, called to schedule appointments and continue doing the screening and referral process. So this is our protocol for a positive screen using the PHQ-9 and GAD-7 screening questionnaire. As you can see, there are 5 levels of referrals, from symptoms ranging from no symptoms to severe depression. And basically, based on the score, they may require a rescreen the next year, a rescreen at the next visit, or referral to child psychology and or child psychiatry with SSRI. So this was our mid-year assessment As you can see, about 3 months into our study, we had over half of our patients being screened, and we started with about 8.5 being screened. And by July, we had close to 70% of our patients being screened. Our goal was to screen 90% of patients with CF by September 30th, and we exceeded our goal, and we screened 100% of all eligible patients. So out of those that screened, 48.5% of our patients did screen positive, and out of those who screened positive, 87.5 were referred for intervention, and only 12.5 refused help. This is a graph that shows kind of where our patients were referred to. So about half of our patients were referred to child psychology and or child psychiatry, and these were in-house referrals. The other refers to our out of EHS referrals, maybe that they wanted to go to another child psychiatrist or child psychologist, maybe due to personal preference or insurance issues. So future plans, we're hoping to continue our annual depression screening as a standard of care as a CF center and address any barriers such as insurance refusal or patient refusal. I think we should also consider caregiver burnout and start screening our caregivers for depression and anxiety. And for me personally, this QI project really sparked an interest for QI in general and for mental health in our patients. And so I really hope to continue QI projects in the future as a fellow in pediatric pulmonology. Thank you. Any questions? Yes, sir.
If you had focused on a different chronic disease, don't you think you would have gotten the same level of depression and so forth? There's nothing unique about CF.
No, yeah, it's definitely with any chronic illness. I think there's depression and anxiety that can be more prevalent in those populations. So I think it's something that we should all be more aware of as physicians.
You talked about resources, referrals for the patients.
Yes, sir.
What about the parents?
And I think that would be the next phase of of this project, to start screening our parents as well for caregiver burnout. Any other questions? Thank you.
Again, from Pediatrics, Dr. Blake will talk about detection of postpartum depression in NICU mothers.
Hi, I'm Ann Blake. I'm a third-year pediatric resident, and our project was detection of postpartum depression in NICU mothers, and my faculty mentor was Dr. Goins, and we were the clinical leads on this project. Postpartum depression is a well-documented phenomenon in which a mother experiences clinical signs of depression, which are directly precipitated by the birth of a new child. The goal of our QI project was to institute regular screening of postpartum depression in mothers of NICU patients, and we also set out to appropriately refer mothers to mental health services who screen positively for postpartum depression. So, what is postpartum depression? In the literature, postpartum depression is recognized as the most common mental health complication of childbirth, and the CDC reports that in the United States, approximately 1 in 8 women experience postpartum depression. The CDC reports that mothers of preterm infants, mothers of infants with birth defects or disabilities, and mothers with difficult pregnancies are at increased risk of developing postpartum depression. These conditions are the bread and butter of any NICU, and yet currently the only common tool for mitigation of parental stress or grief is referral to the NICU social worker, and these referrals are made on a subjective basis and generally in the context of extraordinary circumstances. However, there's been an objective screening in place for years in the outpatient pediatric setting. and we have had a tool to detect postpartum depression in the mothers of healthy babies for decades. The practice of using the EPDS as a postpartum depression screening tool in the outpatient setting has been a gold standard of care in the United States since 1987, when the screen was introduced by the British Journal of Psychiatry. We know that generally women spend more time with their children's pediatrician than with their own doctors in the postpartum period, and it's currently recommended by both AAP and ACOG to screen mothers for postpartum depression during routine infant well-child checks in the outpatient setting. The EPDS is validated to measure postpartum depression at 2 weeks and 2 months postpartum, and that's currently what we do in our outpatient clinic. When a patient scores 10 or greater or answers in the affirmative to questions regarding thoughts of self-harm or increased cheerfulness, the patient's obstetrician is contacted and immediate referral is made for management of postpartum depression. And briefly, here's a copy of the EPDS. It's really straightforward. It's 10 questions. It takes 2 to 5 minutes to fill out. It's in very plain language, and it's available in both English and Spanish. And if you refer to questions 9 and 10, they're very direct. The thought of harming myself has occurred to me. So it's really simple. So we set out to institute objective screening of postpartum depression in the NICU in the same manner that we've been screening mothers in the outpatient setting for 30 years. We put forward the following aims: to increase screening and to provide appropriate referrals to positively screened mothers. The ultimate goal was to change the standard of care to treat NICU mothers with the same screening standards as the mothers of healthy babies, as universal screening is already implemented in the newborn outpatient clinic, and the ultimate outcome measure is the number of screens relative to the eligible population. And our stakeholders involve everyone in the NICU, from the patients themselves to our social workers, our nurses, and our attendings. So to implement standard screening in hopes of really helping NICU mothers, we approached the project with the classical PDSA cycle format. In PDSA Cycle 1, our first phase was to educate the NICU staff on the project, and during this time, we also obtained IRB approval to be able to use patient identifiers for later analysis of risk stratification of screens. We let the staff know that we would be beginning screening in the beginning of April. And in April, we began screening, and we walked around with this poster several times a week, going pod to pod to explain the project that was rolling out. And it has lots of glitter and birds, and we hoped it would attract attention to draw attention to our project. During our first PDSA cycle, we continued education. We used the poster, and we had folders in every pod with blank screens and made them readily available. But then we studied the initial rollout of our first PDSA cycle, and the results were troubling. 9 out of 83 eligible mothers were screened. However, despite the small number of screens, 1 was positive. So we thought, at least, okay, there's a need here. We just need to continue encouraging better screening. So we learned from PDSA Cycle 1, and we made adjustments, and we started staff education at staff meetings in addition to going pod to pod. And we made the following changes. We asked unit clerks to place stickers on the fronts of new charts as reminders, and we added a reminder within baby steps, which had to be done manually, so at least one person per chart would have to remember to put that in. And then we moved the poster that was so glittery and we'd been walking around with to directly in front of the staff break room so that people would see it more commonly. We used these adjustments to start PDSA Cycle 2, and throughout this time, EPDS screening of mothers continued. And the plan and do cycles were identical for PDSA Cycles 1 and 2. So after making those adjustments and learning from PDSA Cycle 1, we monitored our progress for the study of PDSA Cycle 2. And the improvements were considerable. We managed to screen 68% of eligible mothers at the 2-week mark, and we noted that 13 screens were positive. All but one person was referred, and from what I understand, that person was discharged shortly after the screening, so we assumed that they were caught in the outpatient setting, but we didn't verify it. But that's the one person that we missed. And in general, we felt that we were really making progress, and we were pretty excited, and we were really helping mothers take care of themselves. They could take better care of their baby, but then something happened. And an EPIC rolled out at the end of October, and as I'm sure you know, it changed the standard of practice for everyone in all aspects of patient care, let alone for my QI project. And we weren't really sure how to improve in the context of EPIC because we still needed to figure out how it worked. So we allowed the project to continue as is with the improvements we'd already made. So when we review the post-EPIC portion of this project, screening rates were much lower, but we still managed to catch 4 women who were in need of referral. And when we look at the data over the course of the entire study period, it's clear that PDSA cycle 2, which is the immediately pre-EPIC portion, was most successful. And that's when we were attending staff meetings and we had reminders and baby steps. And I think it's reasonable to assume that after rolling out EPIC, people were less inclined to take on extra documentation, as everyone was sort of trying to learn how to use EPIC without worrying, trying to just to be able to complete the daily work of the ICU, let alone to fill in extra screens. So, and then part of the signed note in terms of what came of this project, we had obtained IRB approval to use patient identifiers in this QI project to be able to study if certain neonatal and maternal risk factors increase the likelihood of postpartum depression. And we stratified everyone by about 18 different factors. What we found with the available screens was that the greatest risk factor for postpartum depression was whether or not someone was a first-time mother. However, when we looked at the characteristics of the screened patients, it appeared that in general, the patients screened were healthier and not necessarily truly representative of the actual NICU population. For example, we should have seen a greater percentage of screened patients on respiratory support instead of on room air. So this may be a real confounder, and it may be due to the lack of standardization of implementing screening, and we may feel more inhibited to the point of true bias about asking a mother of a very sick child how she's doing. But that's where there's room for improvement, because all mothers should receive the same standard of care. Despite this, when we reflect on the data as a whole, we successfully referred 17 women whose depression may have not otherwise been detected. And amidst all of the other data, the referral of 17 women to mental health services who may not have otherwise received help is perhaps our greatest outcome measure. So for this project to continue in the future, the most important improvement implementation would be making EPDS screening part of the standard NICU EPIC note with pop-up reminders as it is currently in the outpatient setting. And that is what I think the suggestion should be for our future PDSA cycles. We could also begin to complete the screening in the NICU follow-up clinic as the screen is validated for up to 1 year postpartum. For study purposes, I think it'd also be helpful to include the data from the outpatient newborn clinic for comparison and screening for both screening and depression rates in the outpatient clinic versus the NICU. And I do think that this project warrants continuation in the future, and I think it presents the opportunity to truly help the mothers of babies requiring ICU care. Further, according to the literature, this is not a standard of care at any other institution, and this project gives Erlanger a chance to lead a paradigm shift in how we treat the mothers of our youngest ICU patients. And after all, we're here to take the best possible care of children. And we know that to take care of children, mothers have to be well cared for too. And before I conclude, I really have to acknowledge the dedicated work of one particular nurse practitioner, Sarah Myers, who approached this project with tremendous passion and empathy once she heard about it. And she was really instrumental in making sure we had boots on the ground to carry this out. And she just showed so much empathy in caring for our mothers, talking to them, making sure they got appropriate referral, and to also help make sure it makes sense of the data we collected. And so we couldn't have completed this project without that kind of buy-in. So thank you. Questions? It's a difficult question because we don't have residents in the NICU all of the time. And I think when we do have residents in the NICU, because this is familiar in the outpatient setting, it's much easier to implement. Having said that, the times of our highest rates of screening were not when there were residents in the NICU. So I think that at that time, that means that it was really the work of nurse practitioners, who were taking ownership of their patients and saying this is something that is really going to help. So I think that that's, once you have a nurse practitioner buy-in, you're golden. So, all right. Any other questions?
The plan is after our next and final presentation, we will disperse and let the judges meet and decide on the awards, and we will reconvene exactly at 12:30 So you have a little break to get a bite of lunch, perhaps, and we need everybody back at 12:30 for about 5 minutes to announce the winners. Okay, our next and final presentation is from Nursing and Surgery. Dr. Bell and Kayla Whitaker are going to address intraoperative blood product administration by specialized trauma nurse clinicians improves adherence to massive transfusion protocol at a level 1 trauma center.
Thank you, Dr. Four. I'm Chris Bell. I'm a 6-year surgery resident last year, and this is Kayla Whitaker. She's our trauma program manager. We're going to kind of take you through this and a little bit about this project that we implemented and some of our results. We have no financial disclosures, unfortunately. So our major purpose of this was to improve adherence and delivery of our massive transfusion protocol in the operating room. So what is a massive transfusion protocol? It's essentially, we know historically from a lot of data and from military times that whole blood is the best resuscitative fluid. And what a massive transfusion protocol does is it mimics whole blood. And that gives you a blood product ratio of red blood cells, plasma, and platelets to mimic what whole blood would be. It's usually activated when you're anticipating a transfusion of greater than 2 units. Nowadays we activate it much sooner because of how more readily we do this. And it's used to really prevent what's called the triad of death in trauma patients: dilutional coagulopathy, acidosis, and hypothermia. And it's been shown to improve outcomes when you institute a massive transfusion protocol when patients need extensive transfusions, usually more than greater than 6 or 10 units of blood. So what is the best ratio? There's been multiple studies looking at this and looking between a 1-to-1-to-1 ratio and a 1-to-2-to-1 or 2-to-1-to-1 ratio. And what that means is 1 unit of red blood cells, 1 unit of plasma, and 1 of platelets versus 2 units of red blood cells, 1 unit of FFP, and 1 unit of platelets. There's been studies that showed that there is mortality benefit. There was a randomized prospective clinical trial that looked at 1-to-1-to-1 versus 2-to-1-to-1. It's called the PROPER study. And it showed that you had reduction in the 24-hour death in patients that were actively bleeding. It wasn't powered enough to show a 30-day all-cause mortality difference, but it did show that people that were bleeding did better when they received better ratios of packed red blood cells to FFP to platelets. So most trauma centers, most academic trauma centers will try to adhere to a 1-to-1-to-1 ratio. So we were having issues with we were doing great in the ER, we were doing great in the ICU, but we were having issues in the operating room of maintaining this 1-to-1-to-1 ratio. So we decided to institute a policy to where we included our trauma nurse clinician, the red shirt, to accompany the patient to the operating room and run the massive transfusion. So Kayla's going to talk a little bit about the red shirt program.
So the Red Shirt program was instituted at this hospital about 20 years ago. They are a group of 12 specialty nurses who respond to all the level 1 and 2 traumas house-wide. So it started in 1997. They also, at a later date, ended up expanding and respond to all the rapid responses and codes house-wide as well. And we started doing massive transfusion hospital-wide in the trauma bay in 2007, and at that time, the Red Shirts were responsible for massive transfusion in the trauma bay. In June of 2015, the Red Shirts actually started, with this project, started running massive transfusion in the OR as well. So you'll see our pre-intervention group was from January of 2007, when massive was initiated in the hospital, to May of 2015, which is the last month that the Red Shirts were not running it in the OR. And then our post-intervention group, June of 2015 to January of 2017, which is when the Red Shirts were initiating massive in the ED and then continuing it in the OR. The resources that we needed for this project was actually quite minimal. We had all the staff, we had blood products, we had everything we needed, but we needed a better ability to communicate with the blood bank, from the red shirt in the OR to the blood bank. So we got 2 dedicated telephones that were assigned, one to the blood bank, one to the red shirt, and this allowed for ease of communication when one person was in the OR and the other person was in the blood bank. We figured and found out that it was essential to have good communication between these 2 parties to make this work.
So just as far as the study goes, it was a single institute study here. We excluded anyone that was less than 18, but it basically included everybody that was instituted on our massive transfusion. That the key point being that they received an operation within the first 24 hours, which is usually the case in an acute trauma patient. So we looked at their demographic data, their mechanism, their injury severity score, the ratios of blood products from red blood cells to FFP and red blood cells to platelets. And the key thing, as I alluded to earlier, we want to get closer to 1 to 1 to 1 and had mortality benefit. But there's also shown a deleterious effect if your red blood cell to FFP ratio got over 2 to 1. So if you were giving 3 units of red blood cells and 1 unit of FFP, your mortality was higher than if it was 1 to 1. So we wanted to look at the frequency in which those were done. And then over the past 15 to 20 years, there's been a paradigm shift in fluid resuscitation in trauma patients where, 10 years ago, ATLS said 2 years of crystalloid on everybody. Now this year's edition says 1 year and then 1 liter and then look to giving blood products. So there's a big paradigm shift in how much volume we give patients. So these are the numbers of patients we had in each group. As you can see, the age is the standard, pretty banged up 35-year-old male with a pretty high ISS. That's to be considered an acute trauma patient. For severe trauma patient, ISS is usually over about 16 to 18. Predominantly male. And then the pre-intervention group was interesting. We had majority blunt, and then our post-intervention, we transitioned into more of a penetrating trauma activation on these. And that's kind of, we were just recently at a national meeting, and it seemed like that echoed a lot of patients. The penetrating trauma numbers were up at other institutions as well that are historically predominantly blunt trauma centers, which we are. So this is the kind of the meat and potatoes of everything. This is the intraoperative ratios that were given of packed red blood cells and packed to platelets, or to plasma versus packed red blood cells to platelets. So if you look at, this is standard with anesthesia alone, and this is with anesthesia and the red shirts, essentially the red shirts running the transfusions. So we went from a ratio of 1.8 to 1 to a ratio of 1.2 to 1. And then our platelet ratio went from 1.2 to 0.9. So we were actually ahead of the curve of giving more platelets. We did not show statistical significance in this category, mainly due to our sample size, but it did trend towards that. Because we were concerned about the variation in how many times we were over the 2 to 1 ratio, we wanted to look at the variance in our data. So we looked at the variance in the anesthesia versus the red shirts, and there was a very significant difference in the variance of how many times they were over that 2 to 1 ratio, which is illustrated better here. So the percentage of cases that the 2 to 1 ratio was greater than 2 to 1 was almost 14% versus 4%. And this is, over 2 to 1 ratio is kind of where that mortality benefit is seen. And then one of the things that we weren't expecting to find, this is probably one of the things that kind of was a wow moment for us, is how much crystalloid volume was decreased by doing this. Whether that's because we were getting better hemodynamics because the transfusions were running better, or whether we were taking over the resuscitation and giving less crystalloid, I don't know, but this is a very significant difference in our population. We didn't show a statistical significance in mortality difference, but you can see the percentage, the absolute percentage differences there. 40% in the pre-intervention group and 25% in the post-intervention group. This was a absolute difference there of 15%. So here's some of the lessons learned.
So the things that we learned from this project was that we improved precision and compliance with our massive transfusion by transitioning the red shirts to the OR, basically to help with this. We also found that we reduced intraoperative crystalloid, which Dr. Bell talked about a second ago. We also noticed the trend towards decreased mortality. The things we also learned about barriers to implementation. So the barriers to implementation is really just getting everyone on board and getting everyone to understand the significance and why it's important and how their role really impacts what everyone else is able to do. So the willingness of the blood bank to come along, the willingness of anesthesia to let the red shirts be in the OR with them, the willingness of the OR personnel to understand there was another person going to be in there and how that was going to change their process. So the next steps and unresolved issues. So more recently, we've actually had the red shirts do all of the massives house-wide. So we've really transitioned to that. The blood bank really seems to appreciate that because they have noticed themselves with more standardization, they have one person that they're used to communicating with, and it just tends to work better. We've also continued to educate people on the importance of the trauma nurse running the massive transfusion and the importance of the adherence to the MTP protocol. Our plan in the future is to look at outcomes for ICU length of stay and for vent days to see if this helps us decrease those numbers. We also continue to look at the wastage of blood products, and this is this is our unresolved issue, I should say. We obviously don't want any wasted blood products anytime that we do a massive transfusion. We did have an incident where we did waste some blood products, and we were actually able to get the group of people together who normally run the massive transfusions, and we were able to figure out why this occurred, how to fix it, and we have done another process improvement project with the blood bank since then to make sure that this doesn't happen again. Any questions?
Well, thanks, everyone. We appreciate your participation, and we'll see you back promptly at 12:30.